Hello everyone and big thank you for being here today. I am Ms. Saxena along with my colleague Dr. Deepika Chawla from Medical Services. On behalf of Jagsonpal Pharmaceuticals Limited Pharma Division would like to extend a warm welcome to the experts and attendees for joining Scientific Sangam 27, a part of 8 series, The Art of Science and of Birthing, organized by ISOPARB Prayagraj in association with Allahabad, Lucknow, Bareilly, Obs and Gynae Societies, and academic partner Jagsonpal Pharmaceuticals Limited, makers of Divatrone, Injection Maintane, and Divagest. Please note this webinar is granted 2 ICOG points. We would like to present our Divatrone 10 mg tablets, the fully indigenized, micronized dydrogesterone, the only brand having 36 months of shelf life. Jagsonpal would like to thank the experts and attendees for joining us today through this webinar, The Art of Science of Birthing. Dear attendees, if you have any questions, suggestions, clarifications, please post it in the chat box or Q&A box, which will be answered. We shall also enable audio of attendees to speak up and make this webinar more interactive. So please raise your hand if you want to speak up. Please note this webinar is streaming live on Facebook. The link is already being shared in the chat box for you to circulate on your WhatsApp groups. For today's Art and Science of Birthing, I welcome organizing chairperson, Dr. Ranjana Khanna ma'am. Ma'am is founder president, ISOPARB Prayagraj. She is also ICOG governing council member, vice president Foxy 2017. Ma'am, I request you to please kindly initiate this session. Thank you.
A very good evening to everyone. And at the outset, I would want to welcome the chief guest, Dr. Laxmi Shrikhande, the guest of honor, Dr. Sheela Mane, our seniors who are here, Dr. Manju Verma, and we have our friends from Lucknow, and we also have our friends from Bareilly, and of course, my own team from Allahabad Society. So welcome all. And we also have a few guests, like we have the chairperson of the Practical Obstetrics Committee, Dr. Mitra Saxena, who's joined in. And I welcome you, Mitra. And I would also like to welcome Dr. Rohan Kola. He'll be joining if he hasn't joined, that is. He's from Novo Nordisk. And he will tell us all the details regarding availability of recombinant activated factor 7. So before we start, we bow our heads to Lord Shiva. So today, it gives me great pleasure to welcome the chief guest, Dr. Laxmi Shrikhande. Can I have her CV, please? She is the ever-smiling, most gracious Foxian, and of course, she's the chairperson of ICOG. And since I am a governing council member, So I am really impressed with her persona. So Dr. Laxmi, you're most welcome. She's been the National Corresponding Editor, Journal of OBGYN and National Corresponding Secretary, Association of Medical Women, India, founder, patron and president, ISOPARB Vidarbha chapter, and chairperson, IMS Education Committee, president, Association of Medical Women, Nagpur Ratna Award. Of course, she deserves it. And received Bharat Excellence Award for Women's Health, received Mehru Dara Hansotia Best Committee Award for her work as chairperson, HIV AIDS Committee, and appreciation letter from Maharashtra government for the work in the field of Save the Girl Child. She's a very good orator and she's got several orations to her credit and publications to her credit. So welcome, Dr. Laxmi Shrikhande, and please, we want to start this by a few words of blessings from you.
Thank you so much, Dr. Ranjana. Because once you invite me, I just can't say no to you, because you know, parallel our 3-day course is going on, Essentials in Genetics. 5 o'clock at ICOG, we are having the combined lecture series for all our course students. But yes, I must appreciate that you are going great guns and doing wonderful work as far as ISOPARB is concerned. And that is the need of the hour, what series you have started. But what you have written, that third stage of labor, it is the grand finale.
Is it the grand finale? The question mark is missing.
Is it? The fourth stage should be the grand finale, because we keep on forgetting about the fourth stage.
No, we are coming to the fourth stage in the next webinar.
We will have to have one webinar on fourth stage.
Of course.
Because there most of the problems occur, because everyone gets relaxed as soon as the mother has delivered the baby and as soon as placenta is out. So fourth stage needs its due attention. And yes,
that is why I've asked the question, is it the grand finale?
So I am answering no. And your topics are very well chosen. That first you are teaching the active management of third stage, and of course the most common complication of third stage is PPH. So I'm so happy that you are teaching about the recombinant factor 7, which is now available, the PPH bundle and the surgical approach. Because PPH is not only causing maternal mortality and morbidity, Dr. Ranjana, it is causing morbidity and mortality to us gynecologists as well.
Yes.
Because we are also suffering so much from the stress related, because it's a nightmare. So it really affects the health of the gynecologist. And we all have seen that suicide case of our gynecologist friend because of a case of PPH. So it is the patient, family, but we doctors are also suffering because of PPH. So yes, you have chosen a very apt topic with very good selection of speakers. And I wish you all the very best for the success of this webinar. And I'm looking forward to have your webinar on fourth stage of labor.
Yes, definitely.
All the very best. Thank you
for inviting me. Thank you so much. Thank you so much, Dr. Laxmi. And now I would like to welcome the guest of honor, our very own PPH lady, Dr. Sheela Mane. You know, when we talk about Dr. Sheela Mane, the first thing that comes to our mind is that she's the PPH lady of Foxy. And you have done so much good work on this, and you deserve accolades for this, Dr. Sheela. And she is currently DNB faculty at KCG Hospital, Bengaluru, ICOG Governing Council member. You are a vice president also of ICOG, no?
No, elect, vice chair elect.
Elect, okay. And president ISOPARB Society, Bengaluru, and then president Bengaluru Menopausal Society. More than 2 decades working for Foxy, really. Vice President Foxy 2014, known as PPH lady. Oh yes.
Thank you, Dr.
Knows, anyone who enters Foxy knows Dr. Sheela Mane. And I thought that this webinar on PPH would be surely incomplete without the inclusion of Dr. Sheela Mane. So, Dr. Sheela, you are more than welcome in our webinar, and just give your pearls of wisdom to us and your blessings.
Thank you. Thank you, Dr. Ranjana ji. Thank you for the invitation. And you know that this topic is very dear to my heart. Yes. So the topics also like third stage of labor, and then you have PPH bundle and factor 7, which is the new molecule now with us, and the surgical management. And we know that every day there are changes happening because PPH scenario is changing in our country. As there is a rise in the incidence of cesarean section, and we know that if we look at the incidence of PPH, it is 2 to 4% for vaginal delivery, but it is 6 to 8% for the cesarean delivery. So that means if there is a rise in the incidence of cesarean section, we are going to face more number of cases of postpartum hemorrhage. The another problem which we are going to face in future is the PAS, the adherent placenta. Okay, so we are seeing again that the incidence of adherent placenta is on the rise. So when we say active management of third stage of labor will come during labor, but when we say prevention of PPH, today the important things are, one is the correction of anemia, because you know, if the patient is anemic, she is going to bleed or she is going to be hemodynamically unstable. Now, I had an opportunity to attend the WHO Global Summit at Dubai. Okay. And there we learned why anemia causes PPH. One is there is increase in the heart rate because of anemia. So with every beat, more blood is flowing. There is increase in the viscosity of the blood because there are less RBCs. Okay. The third thing is there is no lamellar flow in the blood vessels. Normally the platelets are at the periphery. So if there is any injury or anything, these platelets will go and get aggregated, which does not happen in anemic patients. Fourth, there is increased fibrinolytic activity. So the clot will lyse early. And fifth is iron deficiency anemia, which also weakens the myometrium. And it was so beautifully explained, you know, that why anemic patient is prone for PPH. It is not only the blood loss, but all these reasons make her bleed. So I think it is prevention. First is correction of anemia. We can say bara pe bara from adolescent age or antenatal period or whatever it is, we know that. Second is reducing the incidence of primary cesarean section. Otherwise, the younger generation will, so we cannot get away with postpartum hemorrhage. But what we have to learn today is we cannot have zero PPH, but we should have zero deaths due to PPH. So we should aim at zero deaths due to PPH. That means the preparedness matters a lot. And the preparedness will start prenatally, antenatally, intranatally, and postnatally. So all the stages, we have to be prepared to see to it that we prevent postpartum hemorrhage. Now we have a new molecule, again, carbetocin. And we know it really works. Yes, few cases, it may not work, but the blood loss is really, really remarkably less. I have done the study recently, you know, for cesarean section, when we have given IV, we hardly had 50 ml of blood loss, you won't believe. And we have done the assessment of blood loss, and it really matters for our women. It really matters for our women. So we have to see to it that the blood loss is controlled. And then the factors like factor 7 and all that, yes, we also have fibrinogen with us. So we have to see to it that we do not land up there. If we try to see that we prevent, we predict, and we are prepared to manage postpartum hemorrhage. I know all stalwarts are going to talk about surgical management, PPH bundle, emotive trial and everything. And I really wish, and I congratulate you, Dr. Ranjana and Dr. Amita Tripathi. I keep looking at your Allahabad activities. To be very frank, we are not so active in Bangalore. So I really feel, you know, because there's so many activities happening in Bangalore, you know. Yeah. So every week there is something with our BSOG only. But I always see so many activities, and you are very, very active. and you see to it that your series goes on. So once
Thank you
again,
so much.
good luck and congratulations. And I wish all the best to all the speakers today. And thank you for inviting me once again.
Thank you so much, Dr. Sheela Mane. It was a pleasure that you were here. And now I'd like to hand over the session to Dr. Parul Khanna. She is she's IVF consultant in Nova South End IVF Center and ex-consultant OB-GYN and IVF Kailash Hospital. She is founder communicator of ISOPARB Prayagraj. So welcome, Dr. Parul, and please take over the session.
Thank you, ma'am. A warm welcome to our esteemed faculty and dear delegates. We begin with our 8th series of under ISOPARB Prayagraj, Art and Science of Birthing, third stage of labor. Is it the grand finale? Our first talk is on the topic Physiology and Normal Management of Third Stage of Labor. I now invite the chairpersons for the session. Our first chairperson is Dr. Shubha Pandey. Ma'am is head of Department of Obs and Gynae at Kamla Nehru Memorial Hospital, Prayagraj. She is president of Allahabad Obs and Gynae Society with over more than 40 years of experience and special interest in high-risk pregnancy, human reproduction, infertility, cancer screening, and geriatric problems. I welcome you, ma'am. Our second chairperson is Dr. Gayatri Singh. Ma'am is Secretary of Obs and Gynae Society, Bareilly, with over more than 30 years of experience in gynec and obstetrics, and she has been a faculty in UVA Foxy. Welcome, ma'am. I now request Dr. Gayatri to introduce the subject and our speaker, Dr. S.P. Jaiswar, ma'am, and Dr. Shubha Pandey to give her expert comments thereafter. Over to you, ma'am.
Thank you, Ranjana ma'am, and the whole organizing team for including our society in this prestigious webinar. The period following delivery of the baby is the time of relief and joy for all involved. However, this period holds great potential danger for the mother. Complications of the third stage, especially PPH, account for much maternal mortality and morbidity. So third stage of labor can be devastating if not managed properly, as there can be several complications like PPH, uterine inversion, hematoma formation, retained placenta shock, etc. So vigilant monitoring is crucial in its management. We have teacher of teachers, Dr. S.P. Jaiswal ma'am, to give her talk on the topic Physiology and Normal Management of Third Stage of Labor. And I have privileged to introduce Dr. S.P. Jaiswal ma'am. Ma'am is professor and head of Department of KGMU Lucknow and president of Lucknow Obs and Gynae Society and president of ISOPARB Lucknow branch also. Ma'am is recipient of so many awards like Stambh Awards, Sashakt Mahila Samman, Hall of Fame Award, DM Sharma and Madhu Sharma Award, and gold medalist in video presentation. And ma'am has membership of so many associations like Foxy, UPCOG, AICOG, Lucknow Obs and Gynae Society,
Thank you, Dr. Gayatri. Good afternoon and even good evening. Thank you so much, Chandra. Thank you so much, Ranjana ji, and ISOPARB Prayagraj, Amita, and all of you for giving me this opportunity to share my views on this. So, मैं शुरू करने जा रही हूँ. Should I start?
Bilkul.
So why we are so bothered about the third stage of labor? As we know, the third stage of labor is very important, as just mentioned by Sheela ji also and other Laxmi ji also, because this is the condition which is change the scenario. So before starting the physiology of the third stage of labor, we should know about the mechanism of normal labor because they are interrelated to each other. So the normal labor has been divided into 3 stages. Stage 1, as we are learning from our childhood or from MBBS, from onset of the labor to full dilatation, or we can say this from early labor to active labor. And then there's a second stage start from the the full dilatation to the delivery of the baby. So it starts from the pushing, crowning, and the cord cutting. And the third stage include after expulsion of the baby to the expulsion of the placenta and cord. And in this we can also include the after birth care also, because now the fourth stage has come. As we know, the lots of problem occur in the fourth stage, which is the continuation of the third stage. Next. So first we know the physiology, what the factors which are responsible for this third stage. In this we know there is a collaboration for fetus, placenta, as well as the mother. In the changes occur on in all these three components. In the fetus, there is a release of cortico-releasing hormone from the hypothalamus, which acts on the pituitary and responsible for release of ACTH, which acts on the fetal adrenals. And same time, placenta also produces CRH, which acts on the fetal pituitary, and ultimately responsible for release of cortisol, which causes lung maturity as well as brings the changes in the placenta. There is a release of increased oxytocin, increased prostaglandins, increased estrogen, and decrease in the progesterone, along with the increase of the interleukin 1, 6, and 8. In the maternal, there is a change in the form of release of oxytocin, and oxytocin is the main factor which acts on the myometrium, and there is increase in the myometrial receptivity for the prostaglandins, oxytocin, increase in the gap junction, and ultimately this leads to the uterine contraction and onset of labor. Next. So these four phases comes into the this whole process of labor. Next. So now the stages, as I told in the beginning, the stages, the first stage of labor, second stage of labor, and the third stage of labor. Next. As we know, the third stage of labor refers the period following the complete delivery of newborn until the completed delivery of the placenta, which includes the membrane, cord, everything, and it takes around 5 to 15 minutes. Even we can wait up to 30 minutes if everything is going well. So why we are so much bothered about the third stage? Why? What is the importance? As we know, the third stage has very much importance, because relatively we don't thought about the third stage, and you have very less thought about the third stage of labor, because the maximum teaching goes for the second stage, delivery, and other things. But as we know, next, if you don't bother about the third stage, definitely we can go into a problem. Like if you see the scenario, one woman dies every 2 minutes due to the pregnancy, childbirth, or complication of pregnancy and childbirth, in which 25 to 40% is because of third stage complication, which may present as the form of postpartum hemorrhage, retained placenta, shock, even pulmonary embolism, and inversion of the uterus. So these complications may occur on the third stage of labor. Next. So now we should know what is the physiology, how this third stage of events goes into third stage of labor. It's an interplay of mechanical and hemostatic factors. Why is it mechanical? Because as there is a reduction in the size, acts as a mechanical, but at the same time there is factor which controls the bleeding. So this is the related to both. In the mechanical, there is a separation and expulsion of the placenta, and hemostatic factors like retraction of oblique uterine muscle fibers, presence of vigorous uterine contraction, activation of coagulation and fibrinolytic system, and these all act together to make the third stage of labor proper. Next, or normal. Next. Once we see the mechanism of placental separation, you can see that during second stage of labor, the uterine cavity, after that the uterine cavity empties. So once the baby comes out, the size uterine cavity become empty, and so there is a retraction process starts to reduce the size of the uterus. And this because of first and second process, the placenta site has already begun to diminish but the placenta does not become so much compressed or so much small in relation to the uterine musculature. So there is a collection of blood and blood backflow. Next. And this retraction of oblique muscle fibers exert pressure on the blood vessels, so the blood does not drain back into the maternal circulation, because once it is closed, the whole blood enters into the placental tissue, and the blood vessel during the process becomes tense and congested. With the next contraction, the distended veins burst and small amount of the blood seeps between the spongy layer and placental surface. So by this mechanism, the placenta separates from the uterine wall. Next. So this is the mechanism of placental separation. How the primary mechanism is the reduction of the surface area of the placental site. Next. And the secondary mechanism is formation of laceration due to venous occlusion and vascular rupture in the placental bed caused by the uterine contraction. Next. This is the method of placental separation. How this placenta separates. There are two ways of the placental separation. First is the Schultz and another the Duncan. Schultz method is the separation occurs in the central part of the placenta. There is a collection of blood, and the further there is increase in the heaviness because of collection of blood, leads to further stripping of the membrane, and ultimately the placenta delivers. In the Schultz method, the fetal surface of the placenta comes first, and the bleeding is also minimized in this process. Next. Next, in the Duncan method, it detached on the lateral border of the border, and the blood escapes, and that may not help in the separation of placenta. So the placenta separates side by side. Ultimately, the lower edge of the placenta comes out, and if we see the maternal surface is seen first, and there is a higher chance of blood loss. Next. So in this, we can see both the separation of placenta by the Duncan method and by the Schultz. In the Duncan method, the maternal surface comes first, while in the Schultz, the fetal surface comes first. Next. So by examination, we can make out whether the placenta has been separated or not. So before placental separation, if we do the perabdominal examination, the uterus becomes discoid in shape, form in feel and ballotable, and fundal height reaches slightly below the umbilicus. If you do the lower vaginal examination, you can see there's a slight trickling of the blood, and length of the umbilical cord is visible from the outside, remains static. There is no lengthening. In the next, after separation, the uterus becomes globular, firm, ballotable, and the fundal height is slightly raised, and it gives the suprapubic bulging. And if you see the vagina, there will be sudden gush of the blood and apparent lengthening. So this we are reading from our MBBS time. This is the same as here. Next. Next. So these are the signs of placental separation. We taught our resident. There is a sudden gush of the blood, lengthening of the cord, uterus become firm and globular, and uterus rise in the abdomen. Next. Now come to how the hemostatic factors plays role. The hemostatic factors plays role by retraction of the oblique muscle fibers, vigorous uterine contraction following the placental separation, and transitory activation of coagulation and fibrinolytic system. So it acts together to control the bleeding. Next. This is the muscle fibers, oblique muscle fibers, how they act as a living light cager, and at the same time there's a thrombosis, and the anteroposterior of the uterus comes together and act as a myotamponade and responsible for the approximation of the surface and stop the bleeding. Next. So the management of the third stage of labor, these are the important points we have to see before doing anything. For guard the uterus from massaging prior to placental separation. Do not massage the uterus before placental expulsion except when partial separation, and do not pull the umbilical cord before placenta separates, and do not try to deliver the placenta prior to complete separation unless in the emergency of third stage of hemorrhage, and wait for the natural process. So the wait for the natural process, don't do hasten unless there is some excessive bleeding or emergency. Next. So if you see the method of placental separation, maybe in the expectant management, can do the expectant management means wait and watch and see whether there is spontaneous separation and the delivery occurs spontaneous. Or we can go for the assisted expulsion in the form of control cord traction, which is modified non-induced method, or expansion of fundal pressure. Next. In expectant management, placental separation and descent occur spontaneously. So just you wait and watch, and the placenta, use the maternal efforts for the expulsion. Minimal assistance should be given, and this method is practiced when the mother has not received any anesthesia, and oxytocin has been given with the anterior shoulder of the delivery of the baby. That is important. In that we can use the expectant management. Next. In this, the hand is placed over the fundus to feel the signs of placental separation. Once the feature of placental separation occurs and the placenta comes into the lower segment, then we can ask the woman to push the placenta, but always see the uterus should be hardened. Next. In control cord traction, in this, the left hand should be placed above the pubic symphysis, and by the another hand, we have to hold the cord, and the traction should be given in the opposite direction. But always see the uterus should be contracted and placenta should be separated. Next. So that is important, because control cord traction should be done once then we feel there is a placenta is separated and has come into the lower segment, and uterus should be pushed above and backward in the opposite direction. Next. So this is the picture in which we can see how the control cord traction should be done, and especially in the graphical presentation, it shows clearly the uterus should be pushed up and backward, and the cord should be pushed downward, but the traction should be steady, not in a forceful condition. Next. When this is another method, expression of by the fundal pressure. In this, the put 4 fingers of the hand behind the fundus, and third thumb is in front of the thumb. In this, you take the uterus in your hand and do the gentle wrapping. Once the placenta separates, then you can push the placenta down. But in this, be careful, the uterus should be well contracted and placenta is separated. Otherwise, there may be chances of inversion. Next. So after delivery of placenta, then you deliver the membrane by keeping the placenta in your hand and rotating and again. If the membrane ruptures or tear off, then you can use the artery forceps to remove the remaining placenta membrane. Next. So now come to the active management of third stage effect. Till we are talking about the physiology and mechanism of placental separation and delivery. So in this, the active management of third stage has very important role to minimize the time of third stage as well as the minimize the bleeding, which include use of oxytocin, 10 unit intramuscular or IV, control cord traction, and slight massage. This control cord traction and massage should be done when it is required, or the person should be skilled, not by everyone, but after separation of the placenta. Next. So this is the WHO recommendation. In this, according to this, the uterotonic should be used in every woman to prevent the PPH. And it can be used in the form of oxytocin 10 unit, IV, intramuscular, but it is important to maintain the cold chain. And if there is no facility of cold chain in this condition, we can use other drugs also. Control contraction should be done when the person is skilled. In unskilled person, they should not do. And even in the cesarean section, we can use control contraction to minimize the postpartum hemorrhage. Next. So there is again refocused approach for the prevention of PPH by using the active management of third stage of labor in the form of we have to use the uterotonics to prevent the PPH, delay the cord clamping to 1 to 3 minutes, do the control contraction if it is required, and keep vigilant for at least 2 hours to see the PPH, to see the amount of bleeding as well as the uterine contraction, and assure the quality of oxytocin. The cold chain should be maintained. Next. So oxytocin can be used in the form of oxytocin, ergometrin, methyl ergometrin, prostaglandin, and misoprostol. Next, it can be used as prophylactic as well as the therapeutic. Next. So according to FIGO recommendation 2022, next, they have given some recommendation like use of uterotonics for the prevention of PPH during third stage of labor is recommended for all labors. That is important for all births. And oxytocin is preferable even after cesarean section as well as the vaginal delivery. If there is a problem of oxytocin, then in this condition, we can use ergometrin, but be careful, the patient should not be hypertensive. And misoprostol 400 to 600 microgram orally, or if the carbitocin is available, that is 100 microgram IF or IV is also useful drug, especially when there is a cold chain is not maintained. Next, even we can go give orally also. So setting where the skilled birth attendants are unavailable, don't do the control contraction. Sustained uterine massage is not recommended in every case. Post-mortem abdominal uterine tonus assessment is required even after delivery. And once the patient has given oxytocin, control contraction even recommended after in the case of cesarean section. Next. So after delivery, examine the placenta for membrane, see the fetal surface as well as the maternal surface, lobes, blood vessels, cord. We have to examine the placenta totally, whether it is complete or not. Next. So this is about the examination of the placenta. We have to see the margin, membrane, any missing lobe, and even the vessels also. Because if the vessels are two only, they may be associated with some congenital anomaly. Next. So after completing the third stage of labor, ensure the uterus is well contracted, there is no bleeding. Inspect the perineum. If there is episiotomy or laceration, should be stitched. Local area should be clean and sterile pad should be given. Next. After that, we have to see the newborn as well as the mother. Mother should receive mouthwash, clean the body, clean the perineal. That usually we miss these things because after that we go for some other work, but it is important, especially that she should empty the bladder because full bladder can cause the uterine atonicity and bleeding, and watch for the pulse, blood pressure every 15 minutes. That comes into the fourth stage of labor. Next. So the baby should be washed properly, the cord should be washed, it should not bleed, and the baby should be dry, thoroughly wrapped properly, and the breastfeeding should be started as early as possible because it causes a release of oxytocin and helps in the maintaining the uterine contraction. Next. So this is about the third stage of labor. According to Ian Donald, this indeed is a forgiving stage of labor, and in it there lurks more unaroused treasury than in both the other stages combined. The normal case can within a minute become abnormal, and unsuccessful delivery, we have conducted the delivery very nicely, baby is absolutely, can become disaster if we have not managed the third stage. Thank you.
That was a lovely revision class, Dr. Jaiswar. Very
Just
nice.
to summarize in a minute, oxytocin has historically been the uterotonic of choice for PPH prophylaxis. But however, recent data suggests that oxytocin combined with misoprostol or ergot alkaloids like methogen or carbetocin alone are more effective in reducing blood loss. They are more effective than oxytocin alone. And tranexamic acid, that's a new thing and very effective. In addition to oxytocin, before the skin incision and cesarean, or within 10 minutes of vaginal delivery, is very effective in reducing blood loss and improving the obstetric outcome. Delayed cord clamping, this is associated with improved obstetric outcomes. And milking of umbilical cord is a very big no-no, should not be done. Controlled cord traction, as she's told, reduces the risk of MRP. Uterine massage is not very effective, as we know. And vaginal and perineal lacerations, they should be repaired. They should be discovered and repaired. They shouldn't be left. And with the synthetic absorbable sutures, that is the best. And oral medications such as non-steroidal anti-inflammatory agents like ibuprofen, topical anesthetics, they can decrease the perineal pain and the need for additional therapy. So all these make childbearing a nice experience. Thank you, Dr. Jaiswal.
बस मैं ये ऐड करना चाहती हूँ because nowadays we are putting the baby immediately to the breast.
Yeah.
When the baby start sucking, there will be a reflex so that the oxytocin can be released and the placenta expression can be, made easier. So and quite effective. So this is one thing that we can add. I don't know whether it is.
वो मैडम मैंने after care में add कर दिया है. After care में add कर दिया है कि feed the baby as early as possible because the releasing the whatever the oxytocin.
Even before clamping the cord, before clamping the cord, the baby should be put the mother's breast.
Yeah, agree. Ji ma'am.
Thank you.
We do it. Thank you, ma'am. Thank you.
Thank you, ma'am. This was a very crisp and clear presentation. Moving towards the next session, that is,
thank you.
We can say a very upcoming revolutionary molecule. Maybe it may become a potential breakthrough for the management of severe PPH. And the talk will be given by founder, president of ISOPARB Prayagraj, Dr. Ranjana Khanna. And to chair the session, I would like to invite Dr. Lata Agarwal. She is professor in the Department of Obstetrics and Gynaecology, Rohilkhand Medical College and Hospital, Bareilly. She has vast experiences of organizing various laparoscopic, hysteroscopic, colposcopy, and urogynecology conferences. And she has various research publications like on cesarean myomectomy, on some laparoscopic and bacterial vaginosis, and one is a paperless partogram. Welcome, ma'am. And our next chairperson is Dr. Nidhi Johri. She is secretary, Lucknow Obstetrics and Gynaecological Society, associate professor, Saraswati Medical College, Lucknow, chief consultant, Lucknow City Hospital, vice president, APGL Lucknow, and she is treasurer of Lucknow Obs and Gynaecology Society in 2017 and 18, and she had been treasurer for ICOG 2022. Welcome, ma'am. With this, I request Dr. Nidhi Johri to kindly introduce the speaker, Dr. Ranjana Khanna, ma'am. Over to Dr. Nidhi Johri, ma'am.
Thank you so much. First of all, I would like to thank the organizers for such a wonderful topic. And the topic has been taken by our president, ma'am, in a very simple way, which is the basic thing. And now I have got the opportunity to introduce, I don't know how to say, Dr. Ranjana Khanna. She is like, we all look up to her for so many advices, and all the times she is such a phenomenal lady. I have always watched her to be the center of attraction, whether it is academic or it is anything else. So, ma'am, a very, very warm welcome to you in this ISOPARB phenomena of academic bonanza of Prayagraj. Dr. Ranjana Khanna is National Vice President FOXY 2017. She's the founder president ISOPARB Prayagraj 2021-23, ICOG Governing Council member 21-23, President Allahabad Obs and Gynae Society 2013 to 2016. She has been the organizing chairperson, National FOXY Conferences, Scientific Sangam, 15 to 17 December 2023, Prayagraj, Obstetric Dilemmas, Allahabad 2022, BOH, the Triology, Delhi 2017. She has been the organizing secretary, National FOXY Conference, SAVMA 2016, Allahabad. National Award, she has won the National Award of FOXY Achievers Award, FOXY Veera Award, FOXY Dr. D.K. Tank Reproductive Healthcare Promotion Trophy, AICOG 2015, FOXY Smriti Myalan Award, Save the Girl Child, AICOG 2013. She has been faculty at various national, international conferences, IMA, Excel refresher courses, and many webinars. She has delivered the prestigious Dr. Prabha Malhotra Oration 2023, UPCOG, Lucknow. Author of many articles and chapters in various books and journals. She has been the co-convener of FOXY GOPR on epilepsy in pregnancy. And above all, ma'am is a wonderful academician and a wonderful human being. We have been so privileged to have you, ma'am, here. And we always look forward for all the new things coming up. And we welcome you so much. Ma'am, आप लखनऊ भी आओ और हम लोगों के पास आप फिर से ये talk deliver करो. So the mic and the stage is all yours.
I'm going to speak about recombinant factor activated 7A and a potential breakthrough in the management of severe PPH. PPH is the main cause of maternal morbidity and mortality worldwide. It accounts for 25% of maternal deaths globally. Dr. Sheela Mane has talked about this. In India, it is responsible for 38% of all maternal deaths. The incidence of PPH is 2 to 4% after vaginal and 6% after LSCS. Most important cause of PPH is uterine atony, which accounts for 50% of the cases. PPH is defined as blood loss more than 500 ml from the genital tract following vaginal delivery and more than 1000 ml following cesarean section. This is according to WHO 2012. ACOG defines PPH as a cumulative blood loss of greater than or equal to 1000 ml or blood loss accompanied by signs and symptoms of hypovolemia within 24 hours after the birth process. Nice definition of PPH is blood loss more than 500 from the genital tract within 24 hours of delivery, and they classify it into minor blood loss 500 to 1000 and major blood loss more than 1000. Loss of, and now what is massive PPH? Loss of entire blood volume within 24 hours, loss of 50% blood volume within 3 hours, blood loss at a rate of 150 ml per minute for 20 minutes, more than 50% blood volume, blood loss at a rate of 1.5 ml per kg per minute for more than 20 minutes, and sudden blood loss more than 1500 to 2000 ml because of uterine atony. Now, we know that even with excellent uterotonics and active management of labor, PPH remains the leading cause of maternal morbidity and mortality. There is an urgent need for a rapidly active, non-invasive medical treatment to be made available for such life-threatening situations. The initial management of PPH involves identifying the cause and interventions, example, medications, compression techniques to more invasive procedures and surgeries. Blood and fluid replacement is an adjunctive therapy. First, use oxytocin. If not effective, other uterotonics are used. Procedures like placenta and clot removal, laceration repair, uterine massage, bimanual compression of uterus, uterine balloon tamponade are the first-line treatments. One of the recent and novel managements in managing PPH is the use of recombinant activated factor 7. It was initially introduced for treating bleeding episodes in hemophilia patients with inhibitors, acquired hemophilia, factor 7 deficiency, and Glanzmann thrombocythemia. Recombinant activated factor 7 is being effectively used off-label on an empirical basis in treatment of massive PPH. Mechanism of action. Recombinant activated factor 7 acts locally at the site of vascular injury where tissue factor is exposed and activated platelets are present. The primary role is to directly activate factor 9 to the activated form and factor 10 to 10A. Binding of factor 7A or recombinant activated factor 7 to the tissue factor triggers the coagulation cascade, leading to activation of prothrombin to thrombin. Thrombin is crucial in cleaving fibrinogen to form a stable fibrin plug, which helps to stop the bleeding. At the pharmacological doses, recombinant activated factor 7 directly activates factor 10 on the surface of the activated platelets, independent of factors 8 and 9. This activation of factor 10 results in a thrombin burst, leading to conversion of prothrombin to large amounts of thrombin. Now, when we talk about a bleeding episode treatments with recombinant activated factor 7, it is widely used for bleeding disorders, effectively controls bleeding, subclinical bleeding, rebleeding without being affected by neutralizing inhibitors. Rapidly acting, quickly achieves hemostasis, rapidity of preparation and injection of recombinant activated factor 7 allows sustained bleeding control. Now, this is a picture which shows us here that this recombinant, in the first picture, we see that this recombinant factor, it is directly acting on the activated platelets, and then this factor 10 gets converted into the active form and directly large amounts of thrombin are produced. And this forms this fibrin plug, which stops the bleeding. So what is the distinctive feature of recombinant activated factor 7? Lies in its remarkable rapidity, enabling swift hemostasis in bleeding disorders and accommodating naturally the busy schedules of patients and parents. Okay, so we see here that when we recognize the bleed, then it takes 2 to 5 minutes because the reconstitution is very fast. And then low infusion volume, fast administration can be done in 5 ml. And fast peak activity within 5 to 10 minutes only, the effect starts coming. Fast bleeding control in 90% of cases and the bleeding is resolved. So procoagulant agents, including recombinant activated factor 7, can potentially cause thrombotic complications. We all are aware of this. With recombinant activated factor 7, however, the incidence of thrombotic events is very low. Why? Because it's acting locally rather than systemically. Since its approval in 1995, it has been used successfully for over 2 decades. Total estimated exposure to recombinant activated factor 7 in all approved indications was approximately 5.4 million standard doses. Around 217 patients out of 5.4 million experienced thromboembolic, of which 44% patients recovered or were recovering. No case of thrombotic microangiopathy was reported. The favorable safety profile of recombinant activated factor 7 can be attributed to its recombinant nature and local action at the site of vascular injury. Now, it reduces the need for second-line treatment in severe PPH. Now, this was a study which was done by Lavigne, Lizalde, G. et al. In 2015, and they found that 84 women with severe PPH unresponsive to uterotonics were given a single dose of recombinant activated factor 7 infusion. Primary efficacy outcome measure was the reduction of need of second-line therapies, blood loss, and blood transfusions. Primary safety outcome measure was the number of deaths and thrombotic events during the 5 days following the infusions. There was a 44% reduction in invasive procedures with recombinant activated factor 7 compared to standard of care arm. 2 non-fatal VT events were reported in the recombinant factor 7A arm, day 2 and day 5. But in both cases, the event was associated with other risk factors. Example, placental abruption, emergency cesarean, and blood transfusion, and occurred despite thromboprophylaxis. So this was an Indian case series. This was done by the very popular Dr. Navneet Megon et al. And it has been published in a Nigerian journal. He has done this study on 5 cases. In the first case, it was uterine atony, and up to subtotal hysterectomy was also done. Patient lost 3.5 liters of blood. She was bleeding still, and then they ultimately gave her 60 microgram per kg of recombinant activated factor 7. And then after that, the patient has uneventful postpartum subsequently. Now, in the second case, there was cervical tears and vaginal laceration despite suturing, volume replacement, tranexamic acid, vaginal packing, still uncontrollable bleeding. And then this also responded to recombinant activated factor 7 at 60 micrograms per kg. Atonic uterus, there was the third case. In this, bilateral artery ligation only was done. Hysterectomy was not resorted to, and preparation for hysterectomy was done. But in the meanwhile, they injected this recombinant activated factor 7, and the bleeding was arrested after 20 minutes of injection. So another case he reports of atonic uterus, multiple vaginal lacerations, and the patient and the husband wanted to preserve fertility. So they decided to use recombinant activated factor 7 and go ahead with laparotomy in case it does not settle. But then it settled beautifully after giving recombinant activated factor 7. Now, another case of atonic uterus and bleeding from the fibroids was there. So in this, they had to give recombinant activated factor 7 in a heavier dose of 90 micrograms per kg, and effective volume replacement was done. Bleeding got arrested within 20 minutes. So such is the efficacy of this drug. Now, this is another study which was done by Goel A. Nair SC et al. In 2013. And they did this study to control recombinant activated factor 7 to control PPH in acute fatty liver of pregnancy. Control of PPH is difficult in patients with coagulopathy due to acute liver failure. Significant improvement in prothrombin time and APTT was noted after recombinant activated factor 7 administration. Its administration reduced the requirement of PRBC and other blood products. It was a useful adjunct to standard management in PPH, secondary to acute fatty liver related of pregnancy related liver disorders. Use of recombinant activated factor 7 in massive PPH, a study by Burma, LS, Bolte, AC in 2008. 27 cases in departments of OBGYN in Netherlands were given recombinant activated factor 7 for treatment of massive PPH. Main cause of PPH was uterine atony in 82% cases. Recombinant activated factor 7 was given in 85% of cases before hysterectomy. It successfully prevented hysterectomy in 76% of the cases. 89% patients had reduction or cessation of bleeding after administration of recombinant activated factor 7. Significant reduction in blood product requirement. In 89%, blood loss prior to administration was more than 3 liters. 63% had blood loss less than 1 liter after giving recombinant activated factor 7. Hence, it offers promise in unresponsive PPH, avoiding emergency hysterectomy. Now, the Indian approval of this drug. The subject expert committee under Central Drug Standard Control Organization has approved the use of recombinant activated factor 7 in line with the European Medicines Agency for an additional indication. This new indication is for the treatment of severe PPH when uterotonics are insufficient to achieve hemostasis. Drug is marketed as Novo 7 in India. It's a recombinant factor 7A product structurally similar to human plasma-derived factor 7A, approved on 7/10/2022. Prerequisites. Now, this is very important. Don't blame the drug if the prerequisites are not fulfilled. So there are certain prerequisites for using recombinant activated factor 7. Hemoglobin more than 7 gram%, INR less than 1.5. It can be corrected by using FFP at the rate of 10 to 15 ml per kg. Fibrinogen levels, minimum of 100 milligram per deciliter, preferably more than 150, can be corrected by cryoprecipitate 1 to 2 units per 10 kg. We must remember that 1 unit per 10 kg raises the fibrinogen levels by 50 milligram per deciliter. Platelets more than 50,000, pH more than 7.2. For this, we can achieve this by giving sodium bicarbonate. Body temperature within the physiological value, because recombinant activated factor 7 retains its activity in the presence of hypothermia. The strength is 1 milligram per vial and 2 milligram vial. After reconstitution, the product contains 1 milligram per ml activated when reconstituted with solvent. The dosage. Recommended initial dose of recombinant activated factor 7. Amita, mute yourself. Recombinant initial dose of recombinant activated factor 7 for treatment of PPH is 60 to 90 micrograms per kg IV bolus injection. The peak coagulant activity can be expected at 10 minutes. If bleeding continues beyond 30 minutes, a second dose is administered based on the clinical response of the patient. If response is inadequate following total dosage of more than 200 micrograms per kg, the prerequisites for administering recombinant activated factor 7 should be rechecked. Advantages of recombinant activated factor 7. It can potentially serve as a universal hemostatic agent across various indications. Over the last decade, it has proved to be effective and safe in controlling life-threatening PPH as both initial and life-saving therapy. It is associated with very few adverse events, well tolerated, does not carry risk of viral transmission as it is free of any human protein, causes localized hemostasis, has low thrombogenicity, low risk of anaphylaxis, no anamnestic responses. Therapeutic uses. When no blood is available, before metabolic complications develop, in women refusing transfusions, in acquired hemophilia, before symptoms of severe thrombocytopathies, hypoxia and organ injury appear, if correction of INR is urgently needed, before packing of uterus or pelvis, before surgical procedures like hysterectomy and laparotomy, before procedures like uterine artery embolization, ligation of uterine and internal iliac arteries. What are the sub-practice points? PPH is the most important cause of maternal morbidity and mortality. 25% maternal deaths globally. Uterine atony is the commonest cause. Trauma to the genital tract, adherent placenta, and several others. Even with good uterotonic agents and AMTSL, PPH remains the leading cause of maternal mortality. Recombinant activated factor 7 is an effective agent for achieving hemostasis in severe PPH. It maintains a favorable safety profile. This is because of its recombinant nature and localized at the site of vascular injury. We've told this earlier on. RCT has shown 44% reduction in invasive procedure in recombinant activated factor 7 arm when used after sulprostone, that is prostaglandin and antagonist failure, compared to standard care arm. In the Indian experience, recombinant activated factor 7 has been proven to be effective in rapidly controlling the bleeding in different causes of PPH. It is an adjunct, very useful adjunct in PPH secondary to acute liver failure of pregnancy related liver disorders, and it is promising in unresponsive PPH, avoiding the need of unnecessary emergency hysterectomies. Before I say a thank you, all of you are cordially invited to a National Foxy Conference Scientific Sangam 15 to 17 December 2023 at Allahabad. This is going to be a kumbh of knowledge, believe me. Thank you so much. So any questions that anybody wants to ask about the availability, the cost?
Yes, ma'am. I would like to know the cost. And one thing which I think, madam, is that if you open the vial, you have to use that reconstituted medicine in one go. If you keep it for some time, like even 2-3 hours, you should discard that. Is that true?
Rohan would tell.
Yeah, I'll answer that question, Dr. Khanna. And first of all, I would like to congratulate ma'am for a wonderful presentation. It was excellent, very short, very crisp, and all the data points were covered. With that, I'll come to the questions which ma'am asked. So the cost of one vial or 1 milligram of recombinant factor 7A is currently about 41,000. So for a 60 kg woman, and if you are using 60 microgram per kg, roughly the utilization would be around 3 milligram. So the overall cost will come to about 1.2 lakh Indian rupees. Now, whether can it be used after reconstitution for a certain period of time? So after reconstitution, it can be kept for up to 4 hours at a room temperature of 25 degrees Celsius. Now, if you want to use it beyond that, you can keep it in a refrigerator that is not freezing between 2 to 8 degrees Celsius, and it can be kept for 24 hours. So, there is possibility to reconstitute it, keep it for 24 hours and use it in a second dose as well. But since the vial sizes are smaller, probably you will end up using the overall dosage or the vial that you have already opened.
So is it available in Allahabad, Lucknow and Bareilly?
Yeah, it is actually widely available. This was approved for the other indications that you've already mentioned back in 2009, 2008 onwards. In UP, it is one of the largest, UP state is one of the largest users of recombinant factor 7A, but for the other indications that you mentioned, for rare bleeding disorders. However, if there is a need, if there is requirement from other indications, whether it is OBG or any other indication, we have supplied NO7 previously also, and it is also available in Lucknow, Allahabad, many of the centers. So we have a distributor and a stockist available in several large cities, and you can contact us, and we will be able to arrange for the availability of the medicines in these cities within a short period of time.
It's available in Allahabad.
Yes.
Where?
Yes.
Dr. Rohan, can it be given to all blood groups? Is there any hypersensitivity reaction?
Yeah,
Yes,
it can be given.
It can be given, ma'am. It is a recombinant factor.
Lata, you're muted.
Am I
I
audible,
would
ma'am?
also like to ask, can we use it in DIC?
Yeah.
Depends
Can
on.
we-
So it is a very, very important.
Ma'am
Yeah,
has
it is a very
already
important.
told us that
Ma'am,
we have been already been using, it has been used for the rest of the indications like the bleeding disorder. So it was long time it has been there, but now we have recognized it as a second line, we should say.
For
because
PPH.
it's very expensive, or OBG, because it is very expensive. So, but still, if there is, we
I
use
think, Dr. Lata, you
Pharma
can
and the
give
rest
your
of the-
inputs.
yeah.
No,
Dr.
we have
Rohan,
not
how
been
can
using
it?
recombinant. We have not used recombinant factor 7. 1.2 lakhs. I think it is very difficult
Steep.
for the patients to.
But you know, Lata, it's still, I feel it is much, much cheaper as compared to a patient's life.
I agree with you, but that the patient's husband should understand.
And we should now, we can
Yes,
actually
you and
counsel
me.
the patient.
That
Yes,
was
it is
brilliant.
available.
Lata, that was brilliant.
With a condition like ours, which is a low and medium, economic country, I think this becomes too much. It has an indication. It should be it should be used
No, but in
specific indications. And I think a surgery will be less costlier as compared to the
drug.
But Rohan, Dr. Rohan,
Yes,
I
ma'am.
wanted to
Yes,
ask one thing, that for medical colleges, you all are supplying at very less rates, na?
Ma'am, the UP
Government hospitals.
UP government is procuring for treatment of hemophilia with inhibitor patients. There is a budget allocated to it for every year for a certain number of vials, which runs thousands actually. So these few patients, they get a lot of care and a lot of these factors for management of their bleeds. So compared to the usage which is happening in hemophilia, the patients in OBG, in PPH, the usage will be very less because it's a one-time usage. And as ma'am said, it depends on what is the intent or what is the condition of the patient. You have to really check. This is not for all the patients. This is not all the PPH patients. So those patients who are continuing, and there is a requirement to the advantage of preventing surgery, preventing laparotomy, preventing invasive procedures. Then this is has data which supports its use by reduction of almost 60% invasive procedures. Now, coming to a previous question, I just wanted to come back to that with respect to DIC, whether it can be used or not.
Yeah, I also want to.
There is a lot of data which says that it can be used. It has been used in DIC. The best results are got when you use recombinant factor 7A when all the conditions are met. Which is
Yeah, platelets are low and INR is increased in DIC. So how can it be useful?
Do you know?
So in DIC, you correct these features.
First, correct.
You correct the platelet count.
The prerequisites have to be fulfilled.
So many things have to be, fulfilled before it can be given.
Yeah,
Madam, if we
And
correct
the other
these
thing is
factors,
if
then
you
we
an
have corrected
INR.
DIC.
INR takes at least more than 2 hours for the reports to come. So the first golden hour which we want to save, this is something which has to be done with, very, very specific indication to be given. It cannot be given to everyone.
And madam, I wanted to add that once we correct those factors, we have corrected DIC.
Exactly.
Maybe
We will not be needing recombinant.
No, I'd like to say that those preconditions are not preconditions only to give recombinant factor 7. Those are anyway required to manage PPH. So by giving factor 7, you cannot get away from trying to correct the blood and other parameters. So they have to be independent.
So DIC is a no-no. Mainly DIC.
Dr. Ranjana, can I ask a question?
Yeah, please do. Please do.
At the outset, thank you for having me. It was so, educative to be a part of such a wonderfully thought out program. Thank you so much. Then I would like to ask Dr. Ranjana and Dr. Rohan, apologies for being so ignorant, but I wanted to ask that in the near future, when are we looking at its price coming down? Because when we look at its mode of action, it really actually it's like kind of sealing a rent in the vascular tree, wherever it is. Because basically, whenever we are dealing with PPH and all that, there are so many multiple factors which contribute to, the excessive blood loss. So I want to know this, that are we looking at any timeline when this price is going to come down, because then it will be available for wider use. Secondly, I may have missed something which is given systematically. How does it not have this, thrombosis? I probably missed that part, but why is it acting only at a particular part? So please explain it again.
It acts locally, so at the site of injury where the tissue factor is then activated, platelets have already collected there. That it acts and directly converts the factor 10 to activated form. And that
is the nidus. That is the nidus.
And that converts the prothrombin into thrombin and then
I understand that. Yeah. So it's really, really important. But another thing is that in PPH, sometimes we go back and forth. So for example, where we have the availability and the affordability and we use it before we, go in for some surgical maneuver. But sometimes we see that even after surgical maneuver, we are unable to control the hemorrhage. So can we do it then also before and after, like? You do this and then you follow it up with surgery, or you do hysterectomy and then follow it up with recombinant. So any cases, I would like to know that.
Yes.
Dr.
I would
Rohan.
like to answer
After
those
surgery, why
both
would you
questions.
like to give? After
No,
surgery.
sometimes
After surgery,
Dr.
the patient
sometimes
is
even
bleeding.
after surgery, you've done a hysterectomy and still, patient has some element of DIC and she's oozing or she's bleeding. So,
But then you have to correct those factors before giving these
yeah,
drugs.
that's what I'm saying. That's what I'm
Is there a
saying.
method
May I
available? Is there a
answer?
method
May I-
available to evaluate the deficiency? Because it is going to affect only when the deficiency is there. So is there a method which is available to find out that? Dr. Rohan.
May I try to answer some of these questions? They are very, very important questions which Dr. Saxena has raised. As Dr. Khanna already mentioned, it acts locally because for the action of factor 7, you need two things. One is tissue factor. This exposed tissue factor is only seen at the site of injury where there is a endothelial tissue is exposed and the extracellular matrix is exposed. Now, the second point is activated platelets. So you get activated platelets only wherever there is activated thrombin, and that is also seen only at the site of the bleed. So because of these two requirements, factor 7 acts only at the site where there is an active bleeding, and hence the documented number of thromboembolic phenomenon outside, that is systemic thromboembolism, is in 0.003 or 0.0003 per usage. So that is with respect to the local coagulation. The second point, whether the cost will decrease, we cannot say what is the timeline, but what we have seen with factors is as the usage increases, the economies of scale come into picture. Right now, before PPH was an approved indication, the total population to which recombinant factor 7 served was almost 5,000 across the globe. So recombinant factor 7A was being produced only for 5,000 people across the globe for different indications. So hopefully and very soon, once the usage becomes increased, once we are able to, there is a chance that there is reduction in the price and availability of this recombinant factor 7. Now, the question whether it can be used after surgery, whether it should be used after surgery. So what we would like to say is the usage of recombinant factor 7A, the approval, the indication that CDSCO has given us and the European Medicines Agency and the other health authorities have given us is after uterotonic failure. And the data that we have submitted is to prevent surgeries. But there is ample amount of evidence and ample amount of data in several case series and several where it has been used after surgery also. As ma'am mentioned, if there is oozing from the subtotal hysterectomy that has been done, even if there is a certain raw area, the patient continues to bleed. There have been cases where recombinant factor 7A has been used and the bleeding has stopped. So I again reiterate that the patient should be chosen carefully. And if the intent is to prevent hysterectomies or prevent invasive procedures, that should be the time and place to give recombinant factor 7A. And after hysterectomy or after invasive procedures, if the patient's life is at stake and if the patient is still bleeding and there is no frank DIC, but you still find that the patient is oozing, there is slow amount of blood that is coming out, or the hemoglobin levels are falling, in that case, there is case to be made for usage of recombinant factor 7. But you have to make sure that there is no overt DIC or consumptive coagulopathy, as we call it as, is not present.
Actually, Dr. Ameya Purandre in Mumbai, he had mentioned that in such a dire situation where hysterectomy had been done and everything, even internal artery ligation and all, and then keeping their fingers crossed and all, they used recombinant factor. That's why I was asking this pointed question. So it has been used, but of course we don't have enough literature to put it on record. But yeah, thank you so much.
Do we have somewhere where we can find out in all the studies, nothing was mentioned regarding the hemophilia status of the patient, whether it was a frank hemophilia or in a carrier, because then the things will be depend. That is why the indication becomes less.
No, these are not hemophilic patients.
No, that's what I'm saying. That the second thing is, if it is that effective, can we use it locally? Because it is acting a local place, so why not use it locally?
Very important questions, doctor.
It's so expensive.
All these patients, which Dr. Khanna presented the data of, they were not hemophilia patients. They were normal patients without any overt deficiency of factors or congenital deficiency of factors.
They were all done, all investigations done.
Yes, absolutely. And
PPH cases were all investigations done before the whole 5 cases which you mentioned.
Ma'am, usually the congenital hemophilia, it's also very, very uncommon.
Patients you normally know from beforehand.
No, not necessarily.
And very, very uncommon in women.
And the carriers.
And one more thing, usually hemophilic patients do not conceive.
They don't go to that stage, you know.
Actually, madam, usually hemophilic patients do not conceive.
Yes. There's so many.
So then these were not hemophilic, na?
Yeah. But it has not been mentioned that they were not hemophilic and not even carriers, because carriers are going to have this type of problem. Not hemophilia, of course, the person will know about it. But what about carrier?
Carrier.
That one should know.
There is some fault in the study.
Yes.
The study should be more extensive.
Actually, Lata, most of it was in index journals only. The only study which was non-index journal was the one done by Navneet Megon. That was in a Nigerian journal.
Okay.
The 5 cases. But now they are working in Mumbai. They are doing cases. They've already done 2.
No, but I think when you post a study,
standardized protocol,
then all standardizations should be done before the study is accepted.
Understand.
I feel what madam is saying is correct.
Ma'am, there is also another indication called as acquired hemophilia.
Yeah.
Wherein any person who develops antibodies against their innate factor 8 or factor 9 or any other factor as such matter. So in those patients, there is actually no hemophilia or congenital deficiency of factors. But since they develop antibodies to the whatever coagulation factors they are there, so that does not mean that they are hemophilic patients, but still recombinant factor 7A has been approved and it has been used in these patients since quite long.
Yes.
So usage in PPH, it's not just
with diagnosed as acquired hemophilia, but in this PPH studies which have been done, there's no mention of that. That's what I'm saying.
So the contention is it can be used in normal individuals, ma'am, in non-hemophilic or non-carriers also, because we are trying to.
You're not following what madam is saying. Madam is saying that it should be very clear in a study that whether the patient was hemophilic or not. She's not saying that your drug cannot be used in a normal person. She's not saying that.
It is not being mentioned in the study.
This is
we have got excerpts of the. We have got only excerpts, na. We haven't read the actual study. So maybe it would have been normal only because if it was hemophilic, it would have mentioned
by exclusion. We are saying, but the study should
by exclusion.
By exclusion.
We must know exactly what is the cause of PPH and then do the treatment, because that should be the aim of everyone.
So that is first line.
Not for placebo.
Absolutely.
Manju Didi, that is the first line treatment. First line treatment, so you have to give Divatrone. You have to see if they are
FDA for this indication.
In our country, 1.2 lakhs is a very big amount.
Very big amount. And if God forbid, if it doesn't work, then what happens?
This is what I'm saying. We cannot afford a 1.2 lakh placebo. We cannot afford a 1.2 lakh placebo.
It's not a placebo. At least there's some ray of hope.
Not for any other.
No, there is some ray of hope that you can end up treating medically without more drastic procedures like, finishing off with the fertility and all. It's your way of thinking. That's
It's your way of thinking.
Yeah.
Ma'am, there is a question in the question and answer. This is,
Nowadays, so many people are insured. So many of these people who come in for delivery have insurance cover.
70% of Indian population is below the poverty line. So this is only for a cream of the society. Yes, you can use it, but not for the 70% of people who are very poor.
Ma'am, there is a question in question back. Please comment on use in placenta previa before hysterectomy. I think the answer is
very much available.
We can use it.
Yes.
We can
try it.
Of course, we
can
can.
try.
Yes.
So, Lata ma'am, you would like to conclude all the things?
Yes, I would like to conclude, and it's always a pleasure to hear Dr. Ranjana. She's been my senior, and she's still just like that when we were in college. And I think it was very informative. Discussions apart, I think it's a good drug, but too expensive. And the company should always think that when you are in India, make in India and make it less expensive. Start manufacturing it in India, it will become less expensive. It will be available to all, because the cadre that requires the drug cannot afford it. These are patients who have not been looked after by the families. They have not had antenatal care. They are coming to a tertiary hospital after being delivered by a dye. So how will they afford a 1.2 lakh?
But nowadays, the high-risk patients are also the IVF patients who are elderly females.
These are affordable patients.
A multitude of disorders.
These are affordable patients. But our line of treatment should be that we have to treat all, whether they can afford or they cannot.
It's not a section. Just
we
Dr.
can't treat
Johan,
a
you want
section
to
of the
say
society.
something?
We have to treat, and these women are in dire need of good medical care and good drugs. So I would request
most of the people who are dying are lower, poor people.
I just want to make 2 points, last points, ma'am. With respect to the availability and cost and accessibility to patients, we are in consultations with government. We are looking at making it available in government hospitals. We don't know when this will happen or which states it will happen first, or what's the way in which this will be available for the patients. But many of the centers are already procuring. Several states have already started using recombinant factor 7A, albeit at a very small scale. So there are local purchases which are happening. There are, if it is being available in hematology departments for the treatment of RBDs, the vials are being requisitioned by the OBG departments, and there is a cross. So a lot of things are being, we have just started to work in this segment. We would like to reach out to all of you and try to understand how we can do this. But points well taken on how to make the medication available across the sections of the society, whether they can afford from themselves or whether they can access the medications through various mechanisms. And last point, in the pivotal randomized control trial, the congenital hemophilia was an exclusion criteria. So that is actually mentioned in the text.
Then it's all right. Good.
Yeah. So that's wanted to make that.
Good.
But otherwise, points well taken.
Dr. Rohan, can you just let us know if that can be used locally also, which Madam also asked?
Yeah, right now we do not recommend it to be used
at the place
locally.
of the tissue injury. Can we use it locally?
We do not have any data.
What is the dose and how it is to be used, like dilution and everything? Or if it cannot be used?
At this point, we do not have any data to suggest that it can work locally. So the time to action by giving bolus is 5 minutes. So we would still suggest you to go with the approved and the route of administration, which we have data for.
Thank you so much.
Where will you give, and locally, where will you give, Nidhi? When you're not sure that she is bleeding from the
you are the placenta, bed is bleeding.
We can give locally. Anywhere we can give locally.
But local, you're not sure of the site where she's bleeding from.
She's bleeding from the uterus.
Look, this is decidua which is
bleeding. So uterus में कितना 5 ml कितना डाल लोगे?
नहीं तुम लगाते नहीं हो गॉस पीस में
हाँ,
आपने
gauze piece.
Then we'll be so
Gauze
scared
piece
that
से लेके मैम
we'll
लगाते
be
हैं,
so
locally
scared
भी
that
लगाते
1
हैं।
lakh is coming
हाँ,
out.
अभी
No.
तो
1 lakh नहीं होगा उसमें, then it won't be 1 lakh. The cost will come back, come lower down, because the amount required to soak those gauze pieces which are going to apply over the residual area will be much less. You can reduce the cost by that.
Correct.
Acha, Dr.
Correct,
Rohan,
ma'am.
Dr.
Very
Atul
correct.
Ganatra is doing those cases in Mumbai. So, have the patients actually purchased this medicine?
Yes, sir.
Okay. Because he was talking that he's done on 2 cases very successfully. Dr. Atul Ganatra was telling us.
Let's move
Yes,
to
sir.
next session. में बहुत late हो रहा है.
Yeah.
So
Thank
once
you
again,
so much
thank you so
for
much,
joining.
ma'am.
Thank you.
Pranam.
I'm sorry.
Thanks a lot,
Thank
ma'am.
you so much, Dr. Manju Verma, madam, also
Thank you so much.
for
Thank
putting up
you.
the problems which we actually will face. Thank you so much. Thank you, Amita.
Thank you. Thanks, sir.
Thank you,
Thanks.
Ranjana ma'am, for this wonderful, very informative talk. And thank you everyone for animated discussions. Moving towards another very important topic, that is bundle approach for PPH. And we have a very dynamic young speaker from Bareilly Society, Dr. Sheela Jamal. And to chair the session, we have Dr. Mridula Sharma, President of Bareilly Obstetrics and Gynaecological Society. She is Director of Dharmdat City Hospital, Bareilly. She is Manita Foxy lead assessor. She is a very active member of Safe Motherhood Committee Foxy, recipient of Foxy Appreciation Award and President Appreciation Award and PSC Award. And she is very active in disseminating knowledge about the PPH and PPH bundle. Welcome, Dr. Mridula. And our next chairperson is very dear friend, Dr. Meera Laktakia. She's Vice President of Allahabad Obstetrics and Gynaecological Society. I can say she's a gem of our society, and she has been at the forefront of all the conferences and all the activities which we have done in past, like SEMA, Foxy BOH, Obstetric Dilemma. She has done a very good work with Safe Motherhood Committee in disseminating knowledge about the PPH bundle and everything that is related to PPH. So with this, I request Dr. Meera Laktakia to kindly introduce our speaker and the subject.
Thank you, Amita. Thank you so much. And those words are coming from the heart of the dear friend. So good evening, one and all. And after that wonderful talk by Dr. Ranjana and animated discussion by one and all on recombinant factor 7. So that's a new kid, not a new kid on the block, but yes, something we are going to look forward to. So I welcome me along with Dr. Mridula Madam from Bareilly. Dr. Sheela Jamal, she's of course a very well-known Foxian and professor and from RMRI Bareilly and menstrual health specialist. We all have seen a lot of videos and a lot of information which she passes on to everybody regarding the menstrual health and hygiene and academics regarding that. So she has wonderful academic body affiliations, that is founder and president of Society of Menstrual Disorders, North Zone Coordinator for YTP2, clinical secretary, member SFM, SMLM. I really do not know the full form of those. Chief lead breast committee of Foxy. She has many research and publications to her credit. She's also been the chief editor, Journal of Reproductive and Menstrual Sciences, editor of Review and Review for Midlife Health, more than 40 publications in national journals and international journals, many chapters to her credit. And we have seen her getting many awards and lots of conferences. So I will not read all of them because we are already running short of time. So I welcome Dr. Sheela to talk about PPH bundle, the next approach, for managing this PPH, the bundle approach, which is the new thing, not exactly new thing, but new approach to manage the PPH. Welcome, Dr. Sheela. Can we have your presentation, please?
Thank you so much, Meera ma'am. Thank you so much, Mridula ma'am. And first and foremost, thanks to Ranjana ma'am and Dr. Amita for having me here. And without wasting much time, I would like to share my presentation because it was a wonderful discussion. We were all hooked and glued to the Novo 7 kind of thing. And that thing we want to have used desperately, but yes, cost is the restricting factor. And what I learned from the previous discussion was that it is not a substitute for the things that we have been learning, doing, and will be learning today. So welcoming you all to PPH bundles. We have all heard a story. एक किसान ने कैसे अपने बेटों को अलग-अलग sticks दी. They all were able to break those individual sticks, but when it was tied in a bundle, they were unable to break it. So same goes with bundles. So International Health Institute defined bundles as a small sets of evidence-based interventions for a defined patient population and care setting that, when implemented together, results in significantly better outcomes than when we compare when they were implemented individually. So that's the entire idea of stitching up practices into a bundle approach. What is the need? Yes, definitely there is. We have to increase uptake and compliance to recommend interventions. Second is they differ from other care packages. Bundles and care packages are different in that compliance is achieved only when all the bundled interventions are completed as well as recorded. Third is compliance for the bundle as a whole implies higher rates of compliance for its individual elements also. It's like a checklist. आपने ये पूरा किया, फिर आप ये करिए, फिर आप ये करिए, and then you complete it, record it, and then analyze what was the result. The bundle approach has been proposed as a potential solution to suboptimal adherence to PPH guidelines, and this received high relevance rates and agreement from the experts for implementation at PHC and hospital levels. So with that, we would like to reiterate and revise what are these bundles. So bundles are two. First is first response, and second is refractory care response bundle. First response is loud, clear, and evident. But for refractory bundles, there are, I will not say controversies, but ifs and buts we will be seeing just now. So PPH, as Ranjana ma'am has very nicely elaborated all the definitions she took into account. Foxy in 2015 has given a definition of any blood loss, irrespective of the route of delivery, more than or equal to 500 ml. And working definition goes like the previous one, that any blood loss after delivery which leads to hemodynamic instability of the patient. So we have these pointers and indicators, but the catch point in background of these bundles is we know these famous or infamous 4 T's of causes of PPH, that is tone, tissue, trauma, and clotting factors. So are these bundles working well for tone as well as tissue, as well as trauma, as well as for coagulopathy? So that is point number 1. So let us talk about this first response bundle, keeping everything in mind, this University of Birmingham trial, trial that Dr. Sheela was also talking about. So first response includes motivate, and it has been recently developed to e-motivate. So we will discuss these components one by one. Second response bundle carries compression, IBT or UBT, non-pneumatic anti-shock garment, and in addition to that, side-by-side transfusion, referral need, and surgical need that we have to assess. So first response bundle, first is E. E is for early assessment by using a trained staff, adequate resources, and help is at your back end. And what we don't have to forget is we don't let the actual definitions to guide the trigger for acting and initiating all our measures that we will be going to use. So what are these measures, or what are these early assessment signs? First is rule of 30. FIGO in its 2019 and 2022 document has also used it. And they have said that this is a beautiful rule to remember by. Heart rate increases by 30. Systolic blood pressure falls by 30. Respiratory rate is more than 30. Hematocrit falls by more than 30%. Urine output is less than 30 milliliter per hour. So this rule of 30 is a very easy, quick, graspable method, doable and implementable trigger to start acting. Second thing is shock index. And also FIGO and WHO recommend using shock index for assessment, especially for volume filling and the assessment of left ventricular function. So shock index is again very easy to calculate. Heart rate divided by systolic blood pressure. Now we have heart rate divided by mean arterial pressure, which is having better sensitivity for predicting morbidity as well as mortality. So normal shock index should be less than 0.7, and it can be taken up to 0.9 in pregnant individuals. If it is going more than 1, we have to be alert and ready to use other things. Another thing is modified early obstetric warning score. This should be available practically in every labor and delivery suite, every OT, in fact, post-labor wards, so that the signs can be detected, picked up, and acted upon. Third is this assessment of blood loss, which is the main component for acting as a trigger to manage PPH. Now, this was discussed by WHO, and this was accepted. In all these care bundles, whenever we were developing that, they have accepted that we actually did not standardize any method of blood loss assessment, and that is the thing that is lacking in first response bundle also. Ki kitna blood loss kaise dekhein, because we have so many definitions. Every clinician judges and perceives the situation differently. So this is one component, this is one area which is actually not standardized as yet, if we are talking about first response bundles. Second is, after we have assessed the situation early, we have to act. So how we have to act? We have to use the M of motivate. So M stands for massage of the uterus after emptying the bladder. So the method used for massaging the uterus is this. This is also known as fundal pressure, fundal rub, fundal massage, and it stimulates fundal electromyological discharge, thus stimulates contraction by releasing prostaglandins also. The massage should be strong enough to squeeze, and the circular motion by fist is almost inadequate, which we were doing earlier. So this has not to be done, rather a fundal rub or fundal pressure has to be instituted for that to become effective in controlling PPH. Then other component is O. O stands for oxytocin. Dr. Jaiswar ma'am has also, she made us a good, she gave us a good revision of all the oxytocins. So what I want to highlight over here is oxytocin is the first line and recommended treatment option for PPH. It has to be given at a dose of 40 milliunit per minute, and that we can make by putting up 20 units in 500 milliliter of ringer lactate. If it is not working, then use methergine, or if you have symptometrine fixed dose combination, that can also be used. Otherwise, oral or sublingual misoprostol, 800 microgram, because prophylactic dose is 600 microgram. Therapeutic dose has to be 800 microgram, which goes by maximum dose of 1000, not 1200 microgram. One thing important here to note is कि हमने पहले ही active management of third stage of labor कर लिया होगा. So if we used 600 microgram misoprostol, then so what is the condition now? Should we use this additional dose of 200 microgram or a complete dose of 800 microgram? Is still not clear. Evidence is lacking, and FIGO has documented that. So it's your call. So I teach my students कि अगर bleeding हो रही है, so if you have to decide which kind of oxytocin you use first. So अभी एक movie आई है, Oh My God, OMG. So I always tell them use Oh My Mother, that is oxytocin, methergine, followed by misoprostol. And third line agent is carboprostol. Carbitocin is not used for treatment of PPH. It is a very good drug for prophylaxis. Half-life is longer, 40 minutes, heat stable. Only contraindications are epilepsy and eclampsia. So carbitocin has been instituted as first line of preventive aspect by many societies, including SOGC recently also, but not for treatment of PPH. So when we come to the third component after motivate, MO, this is T. T is tranexamic acid, fixed dose of 1 gram of tranexamic acid, and you put it up in a dose of 100 milligram per milliliter IV at 1 ml per minute. So ये 10 minute में चला जाता है. And when we have to give it? It has to be given within 3 hours at the time of diagnosis of PPH. If it was unknown when did the PPH start, then take the time of delivery till 3 hours for this to be beneficial in its completeness. When we give it after 3 hours of the diagnosis of PPH or after delivery, the benefits are still unknown, and for that Women 2 trial is going on. A second dose can be given if needed 30 minutes after the first dose and within 3 hours of the start of PPH and delivery, as I have just told. So tranexamic acid reduces morbidity, mortality, need for further interventions if given within 3 hours. So this rule of 3 has to be maintained and remembered. But again, this does not mean that after 3 hours we cannot give it. If there is ongoing hemorrhage, we can always give it. The only contraindications are color vision disorders, renal artery thrombosis, active concomitant procoagulant use. With this, Novo 7 hum de sakte hain ki nahi de sakte hain. So data was sparse. I also had a look for this. If there is a history of veno-occlusive diseases recently or in the past, then we don't give it. It's better to withhold it. Then fourth component is IV. That is MOTIV. IV means IV fluid. We give isotonic crystalloid solutions, ringer lactate or normal saline, and you administer it at a starting dose of 500 milliliter in 30 minutes and continuing doses of 500 milliliter IV in 60 minutes or as the need arises. The catch point here is avoid colloids. However tempting they look, कि अभी कुछ नहीं है जब तक blood आ रहा है तो colloids दे दें, it will reverse whatever good we have done till now. So avoid head starch, albumin, and other kinds of volume expanders. So last E motive ka E that has been added also, and that is optional E, is examination of genital tract for traumatic PPH, because till now we have taken care of. If it is not responding, then just by the reflexes that we all obstetricians have, examine genital tract for the trauma that it may be bearing. And then E again stands for escalating for refractory response measures, because kitna bhi hum aage badh jaye, we have to go by the dictum for the treatment of PPH sooner than later. So we always, it might be, we might be over treating sometimes our patients, but sooner than later is always better. So refractory bundle response or response bundle carries components, compression, UBT, NASG, transfusion, referral, and surgery. But one thing noteworthy here is a continuing dose of uterotonics, whether oxytocin or whatever, and a second dose of tranexamic acid should be administered during the application of this bundle. There was a lot of hue and cry over कि अब जो response bundle है refractory, इसमें ये भी add कर दें, वो भी add कर दें जो पहले response में हुआ था. So it was agreed upon by all the experts that there is no need, but yes, this note should be maintained that uterotonics and tranexamic acid should be continued and repeated. So first is compression. Compression. This is bimanual compression of uterus. Again, we have to rule out any tissue that might be like a subcentrial lobe or whatever. And we have to empty the bladder and put the fist in the anterior fornix and invert the uterine fundus over this hand, which obliterates uterine artery flow, reduces the blood flow, and it tells us whether our other compressive and occlusive methods are going to work or not. Second compression is aortic. We go to the left side of umbilicus, we keep the elbow joint locked, stand at an elevated position, if needed, displace the uterus to right side and palpate femorals to check whether this aortic compression has been working or not. And what we do is we ask our, usually there are residents who are assisting us in compressing the aorta. We ask them, did you touch the vertebra? Vertebral bones tak pahunch jao, wahan tak compression hona chahiye, so that it is effective and it will occlude the blood flow. But this is not a treating measure. This is just a temporary method so that other methods are being arranged, or the patient is, if we are thinking of shifting her to a higher center, if we are in lower care settings. So next is intrauterine balloon tamponade or UBTs. That is a detailed discussion, warranting a complete talk in itself, but just to highlight few things, there are fixed volume balloon tamponade devices and free flow balloon tamponade devices, because again, there is a discussion कि वो intrauterine pressure कितना होना चाहिए, systolic blood pressure से कम होगा, equal होगा या ज़्यादा होगा for it to achieve the efficacy. So what we have to think is, वो fixed flow device है या free flow device है, it should be giving us adequate tamponade. So what are we using? I'm sure majority of the obstetricians must be having a good experience with condom catheter use, Foley's catheter use. Multiple modifications have been done, like Chhattisgarh, our own ingenious modification. But again, for having a drainage channel, when we have put a UBT inside the uterus, it is a query whether we require it or not. These LV balloon, Bakri balloon, then Ebb balloon are good, and they also work fine. And first, the only restricting factor is cost as usual, because the kind of places, especially where we are working in medical colleges, patient 100 rupees ka discount mangta hai, and when we offer them these things, usually a denial comes and we have to resort to other desi methods. When we talk of this balloon catheter sandwich technique is an excellent technique while we are doing cesarean sections, because I'll come to the controversy associated with compression techniques in cesarean section. A point noteworthy is using this suction cannula, which again is not a compression device, but I'll call it an internal suction device. The aim achieved is almost the same. It is building up negative pressure and assisting natural physiological process of contraction and retraction. Personally, we haven't used it. We have ordered, but people who have used it vouch by it. They say it's excellent and work nicely. So maybe it's time we all should be at least giving it a trial. Coming to non-pneumatic anti-shock garment, it is used again, not as a treating condition, but as a temporizing measure until source of bleeding is found out and treated. It is a lower body compression device made up of a stretch neoprene, which closes tightly with Velcro in segments for the ankles, coming to calves, then thighs, pelvis, and abdomen, and is applied rapidly starting at the ankles. Niche wale, yani ke up till the pubic level, we have to use 2 people to tie them, and above that, 1 person can alone tie that. So this is the sequence 1, 2, 3, 4, 5, 6 are mentioned, and this leaves a space for genital manipulation if required. So the thing is, if we are referring this patient, refer her early, and this non-pneumatic anti-shock garment is a real aid, because coming in 4,500 to 6,000 rupees, just look at this statement. It can keep a woman with PPH alive for up to 48 hours. Without it, she may bleed out within 30 minutes. So I think this is an excellent method which can be employed at PHCs, CSCs, and the small hospital settings, because it is buying us very much critical and crucial time to transfer a patient to healthcare and provide further treatment. So it is lightweight, washable, and can be reused up to 144 times. And it is extremely cost effective when we divide. Coming to transfusion, trigger is refractory PPH. If you have to resort to first care, bundle chala gaya, and second care hai, to always arrange for blood. At least 2 units of packed RBCs in hand to transfuse, and further 2 cross-matched. Ongoing uncontrolled hemorrhage hai, to ask for other things also, because all seniors, colleagues, juniors will agree with me that hum har cheez se jeet jate hain, DIC bada rula deta hai. So when once this DIC has set in, things become quite irreversible, and the ratio mentioned here is just a reference. There are deviations to it also. Platelets to be transfused only if there is thrombocytopenia. There is no need to unnecessarily transfuse with and load them with the platelets. Factor 7, we had a detailed discussion, but again, this is not a substitute for all the measures that we take. So surgery, we have whole talk dedicated to surgical methods. Just a word, don't take a delayed decision. Karna hai to pehle hi start kar dete hain. If your statement or your facility is well equipped, uterine artery embolization can be resorted to. Then one thing is no uterine packing. It was completely forgotten till 2 to 3 years back, but ICOG has again come back with uterine packing, and that pack is soaked with thrombin. So we don't have experience, personal experience to nahi hai, literature hai, and it is quite convincing. But belonging to army fraternity, I would like to tell here that army people are using these local aesthetic agents. They are working fine on raw tissues also, buying them a lot of time to, get a triage and evacuate the wounded soldiers. And for PGs, don't use methergine for retained placenta. It's going to land you and us in trouble. A single dose of antibiotic in context of placental retention. The placenta should be extracted, and the single dose of ampicillin can be given, or should be given rather. Uterine artery embolization, we know it's a time-taking measure, but if it is done, it is effective in as high as 90 to 100% cases. So relevance is just 4 points, and I'll take, I think, just 2 or 3 minutes more. When we talk of relevance in application, especially for refractory bundle, Resources are very important. कब करेंगे? Balloon tamponade हर किसी के पास नहीं है. Non-pneumatic anti-shock garment बड़ी से बड़ी facilities के पास अभी नहीं है, तो छोटी facilities बहुत दूर की बात. Drugs or all the drugs available and present of support system and referral facilities. Training. I do, मैं ये करती हूँ, मैंने ये किया, वो ये करते हैं, no. So standardization and need for one common dialogue is the need of our. Second is resistance to adopt changes. अभी हमने Novo 7 में देखा, सबको समझ में आया कि बहुत अच्छी ड्रग है, but कोई कॉस्ट के लिए है, कोई अवेलेबिलिटी के लिए है, कोई कि हम नहीं यूज करेंगे. मतलब देयर आर सो मेनी थिंग्स which we all are accepting कि हम लोगों में change आने में time लगता है. Then updates, yes, these excellent webinars conducted by, kudos to Amita ma'am and Ranjana ma'am for putting up these topics. These are very beneficial for all the commoners, for all the obstetricians like us also. And moving staff is a big problem. आपने आज एक chain को train कर दिया, 2 दिन बाद resign करके चले गए, आपने fire कर दिया, जो भी हुआ. But they have changed now. You have to again train them, and it drains us with a lot of energy and time. One thing important which needs probably a discussion also, cesarean. Are these bundles equally good for cesarean? पहला तो modification चाहिए. IV fluid और oxytocin में हम पहले ही वहाँ पे cesarean में IV fluids चल रहे हैं. So that goes waste. Second is massage is difficult and not even described. तीसरा है जो compression वाले methods हैं वो cesarean के लिए describe नहीं है. Neither for aortic nor for uterine compression. And we all will agree that we tend to resort to devascularization quite early when we are having atonic BPH during cesarean section. So are they relevant? Are they applicable? Do they hold very true for vaginal as well as cesarean delivery is a big question mark. So to answer that, WHO is convening the first meeting of this WHO guideline development group, subgroup PPH bundles on 31st August and 1st September 2023. And with an objective to review the evidence pertaining to approaches for blood loss assessment, as I said earlier, ये चीज़ है जो standardized नहीं है, and discuss and agree on recommendation on this approach to blood loss assessment and use of care bundle for the treatment of PPH, especially refractory bundle care approach. So we all can send our queries. There is a website and the email ID. Dr. Chow is there. He will be taking up all the queries, and I think we all must send. And with that, a big thank you for having me here.
Thank you, Dr. Sheela, for such a wonderful and, stepwise manner in which you covered bundle approaches. This completely has changed the way we are managing PPH. Just a one line I would like to add, पहले जब भी हम लोग PPH manage करते थे, everything used to be haywire. But once we have learned about the bundle approach, things have become easier to manage. So first thing we must remember that when we are going to apply these bundle approach, AMTSL sabne kar liya, trigger is very important. You must know that now this is the time to apply your bundle approaches. And what you said about the moving staff, which is very practical point, but that is why the OR team has been developed in each facility. Where whatever workshop we have done, we have changed the way we are going to train these people. And those 4 people, what the person is doing at the head end, right hand, left hand, what is the person doing at the foot end, This is the systematic approach. And the third final point, which I always want to point out to everybody, that whenever we have a case of PPH, whether it is government or private or whichever facility, do the debriefing session. Relook where we went wrong or what stage we transferred the patient, where we had to refer the patient. So once we do the debriefing, हमारा next step उतना दूर नहीं जाके पहले ही खत्म हो जाएगा. So what will happen is our every case will be a example in itself and a teacher in itself, or we'll remember our steps very well. So do everything together, recognize the trigger, have your team ready, and every moment is better. Now coming to the NSG point, one more thing what we have done in Allahabad is we have created the chain of NSG. We have got NSG from Pathfinders, okay? So from Chitrakoot onwards, from Vindhyachal, which is almost 250 kilometers away from here, Sonbhadra. So the patients are being transferred from there with NSG garment. We have one in between at 80 kilometers, and we have one in the center of the city. So we know how the patient is going to be transferred and where. And we have made these WhatsApp groups of I'm shifting my patient to there. So NSG keeps rotating, and this is how we are managing with
less number of NSG in Allahabad. This is how we are managing it. People can manage because NSG की cost 8,000 रुपए आती है, और 8,000 रुपए हर facility नहीं रखना चाहता, क्योंकि 2 रखने पड़ेंगे ना, एक भेजोगे तब तो एक वापस आएगा. So that is the way it should be. Thank you, Dr. Sheela, for completely talking about the bundle approach, and there's lots more to talk about. I'm full of this PPH thing these days. Thank you so much. Thank you, Dr. Ranjana ma'am, for giving me the opportunity. Thank you, Manju Verma ma'am. She has been our advisor all through. Sujata, Dr. Sujata is here. Gayatri is here. Dr. Pradula ma'am is there. Amita is there. Thank you so very much. It's wonderful. And इसके बाद वाला जो session होगा 4th stage, उसमें भी हम लोग का PPH का secondary PPH and lots of things will be again, you know, how we can help our women. It will be very, very important. Thank you so much. Thank you. Thank you very much.
Thank you, Dr. Sheela. Thank you, Dr. Meera. And Dr. Mridra has to go for an emergency. So I think Dr. Meera has concluded it very well. Moving towards the 4th session, that is very important. That is surgical management of PPH. And we have for this speaker from Puducherry, Jipmer Pondicherry, Dr. Chitra T. And this session has to be taken by Dr. Uma. And Dr. Uma has to go for some emergency. So I am continuing with this session also. To chair the session, we have with us Professor Dr. Manju Verma ma'am. She is the teacher of all of us who are present here. She's past president.
Move on.
Ma'am is, we can say, the strong pillar on which the EOG stands. And welcome, ma'am. And then our next chairperson is Dr. Sujata. She is professor in unit head, Department of OBGYN, KG Medical College, and she is recipient of various awards like Dr. C.S. Don Award, Appreciation Award, Abad Custom Award, and she had more than 100 national international papers published in the reputed journal. And with this, I request Dr. Sujata to kindly introduce our speaker, Dr. Chitra T. Dr. Sujata, over to you.
Good evening, everybody. And first of all, thank you for organizer to giving this opportunity. Good evening, Manju ma'am. Good evening, Ranjana ma'am, to be present here. And really it is, I'm listening since beginning, and really it is the just revision, which is going from the physiology and the recombinant, which has a lot of the discussion. Then PPH bundle block, that is very, very important approach. That is very important. Now we are and now the final, that is the need of the treatment, that is the surgical, how to manage the PPH by the surgery. So I am proud privileged to introduce our next speaker, Dr. Chitra Raju. She is professor at the Obstetric Department of Obstetric and Gynaecology, Jawaharlal Nehru Institute of the Postgraduate Medical Education and Research, Jipmer, Pondicherry, India. She has received many awards, in which very important, that is the Dr. Purnima Nadkarni Award for the best paper in ISAR 2020, Srimati Shanta Hanji Gold Medal.
Sorry,
FSI,
we can just reduce
these are the few times when we read, we should read actually, which we have just forget what we have received. So let me continue. KD Nair Award for the best paper presentation at the IFS 2018. Dr. Asa Rao Award for the best poster presentation in ISAR 2017. Best Paper Award in Infertility Topics at International Conference AOFOG in 2019, C2D in 2019, GUCOG 2022 Conference. Received Wonder Foxian Award in 2019, which is facilitated by Foxy President. Dhira Award in 2022, which was facilitated by the again Foxy President. She had many publications in her credits and contributed few chapters in the textbook. Her area of interest is reproductive medicine, laparoscopy, and very important, that is the medical education, which is also I love. And secretary of the, at present, she is secretary of the IFS chapter Pondicherry, treasurer of the OGSP Society. So now she is going to give her talk on the surgical management of PPH. So Dr. Chitra, now over to you.
Thank you, ma'am. Thank you so much for that kind introduction. And I really thank Ranjana ma'am and President Secretary of all the societies for giving me an opportunity. Though I am an IVF specialist, I work in a central government institute, tertiary center. So we have to cater to the things obstetrics 24/7. So it is my privilege to have this topic for presentation today. There's a surgical management strategies in the management of PPH. So overview, I like to tell about what is a golden hour during vaginal delivery, cesarean section, what are the various aspects, surgical aspects, what is anticipated, unanticipated PPH, and coming to the conclusion. As we already know that the discussion happening from last 2 hours that postpartum hemorrhage is most common cause of morbidity and the mortality. And 3 to 5% of this patient, we have an incidence of 3 to 5% in our institute, and 1 in every 1,000 people undergo hysterectomy, and 4 in per 1,000 deliveries have an compression sutures. So it becomes a very important, like effective management should be included with a multidisciplinary approach, and you have to have a structured approach to any patients with PPH. So obstetric hemorrhage becomes a rapid life-threatening. So it's very important for us to pick up the signs of PPH and early. So what is the rule of 30? 30% of drop in the blood pressure, heart rate increases by 30, systolic blood pressure drops by 30, hemotic rate drops by 30, respiratory rate increases by 30, urine output decreases 30 ml per hour. So all these things will play a role in this identifying the PPH at the earliest. So very important for everyone is that first hour is a golden hour. So as already Dr. Snehal has already told, this is a pictorial guide which should be put in all the labor room, because underestimation is the one which leads to the diagnosis, delayed diagnosis and delayed management. So it's very important for us to diagnose it early. So important to train our residents, the nursing staff about the pad, which is what is a ml with the pad is so, or if it is one kidney train contains so much of blood. All this should be trained to the people so that they give an alert and tell us whenever there's excessive bleeding or excessive passage of the clots. So this is an algorithm where we have to do whenever PPH occurs, we should work in coordination with an anesthesiologist. So as first hour is a golden hour, within 30 minutes, if at all you see that the patient is having a bleeding, empty the bladder, massage the uterus, examine the vaginal cervix to look for any traumatic PPH, administer the medical management. Meanwhile, on the other side, concurrently you should start that wide bore IV axis, administer oxytocin, start resuscitation, grieve crystalloids, colloids, and it's always important never to give excessive IV fluids, and it should be given only until the blood is available. So within 30 minutes, with all these measures, still the bleeding is not controlled. Yes, you can shift the patient to OT and you can do the tampon over there. Meanwhile, the anesthetist should be informed about the artery line, central line, administration of the vasopressors, administration of the blood. And already mentioned by Snehal, administration of blood in the ratio of RBC, FFP platelets 1:1:1. Okay, after the 60 minutes, still with tamponade bleeding is not controlled, then you should go for this procedure, that's laparotomy, where our role comes as a surgical management with the devascularization, but then compression sutures. Between this and the hysterectomy, what lies is what Ranjana ma'am has told is this recombinant factor 7A. In cesarean section, when you're doing cesarean section, usually we might underestimate because sometimes the suction, lot of the blood will be taken over by suction, so we won't be knowing. So the perception of the every obstetrician, it should know that if there's a uterus is flabby, if you assume there is an excessive blood loss, or if there's an angle extension, or if at all none of these findings are there, but if there is a hemodynamic instability like change in the heart rate, blood pressure, pulse oximetry, then there should be a high suspicion the patient can go into PPH. So there is an ordinary communication should occur between the obstetrician and anesthesiologist, because anesthesiologists really play a very important role in the management of this PPH. So as obstetricians will be taking care of the rapid surgical hemostasis, the anesthesiologist should form a checklist and start writing the hemodynamic stability of this patient, start arranging for the blood, and till the blood products come, they should be try to do the plasma expression with the crystalloids. In spite of this, again, if this PPH continues, then comes your surgical conservative surgical hemostasis. And between this, I told recombinant factor 7 plays a role. So whenever you shift a patient to the anesthetist, you have to tell what is the type of delivery, when the PPH occurred, what is the drugs which all have been given, what is the allergies if the patient is having, what is the pulse rate, blood pressure, urine output, venous access. Very important is the amount of dehydration before delivery. Dehydration might aggravate the PPH because when there is a dehydration, the hypoxic of the tissues occurs. In that way, the uterus will fail to contract effectively. So that should be very well taken in any patient in labor. So again, this is one of the thing with shock index, which already mentioned. Yes, you have to see that if the shock index increases, the mortality from 11% in PPH with no shock index goes to as high as 40% with severe shock index. That is more 0.5. So any patient in PPH, you have to calculate the shock index, which is nothing but heart rate divided by systolic blood pressure, and try to maintain it less than 0.6. These are the various surgical management which I'll be going to elaborate. So if the patient is in vaginal delivery, I told you golden hour is 1 hour. Within 1 hour, if there is a refractory atopic PPH, if there is a vaginal cervicitis, laceration, peritoneal laceration, vulvar hematoma, or any interuterine maneuvers like MRP has occurred or uterine rupture has occurred, yes, the patient is, you have to take her for laparotomy. In post-delivery, yes, the causes of PPH can be atonicity, or it can be uterine angle extension going into the uterine vessels, or it can go into the lower uterine segment leading to corporexis, or can lead to broad ligament hematoma. And all cases of placenta previa, placenta accreta are high risk for postpartum hemorrhage. So a stitch on time saves 9. This is a various surgical uterus conserving surgeries. What are the compression sutures? One is a B-Lynch, that is brace sutures and its modifications. Then the other is a Heyman, the simple brace sutures with modifications. And systemic vascularization procedure involves a uterine artery, ovarian vessels, and modification of these two vessels, and bilateral internal iliac artery ligation. So way back in 1997, Christopher B. Lynch was the first one to introduce this B-Lynch sutures, which he has used to control massive postpartum hemorrhage in at least 5 cases. And from that time, it has become a golden, a golden step in a patient's for the control of the PPH. So majority of the people know how to put the B-Lynch sutures. I like to explain to you. You very important, like you have to use a chromic catgut 0. You should never use the delayed absorbable or non-absorbable sutures. And the position where you have to take, if this is an hysterectomy incision, 3 centimeter below the incision, and force you should go 3 centimeter below the incision and come out 3 centimeter above the incision. Then you have to brace it around the fundus of the uterus, and this brace should be at least 4 centimeter from the cornal end. Then you should go through and through from at the level of the uterus segment into the myometrium, come out, and again brace over the fundus of the uterus, and on the left side insert a 3 centimeter into the myometrium, endometrial cavity, and come out 3 centimeter below the lower uterus segment. Once you do, this is the last 4th picture, is the one which is picture which shows at the end of this brace sutures. When you apply this compression sutures, this is how the B-Lynch sutures appears. Can you see? Once you do that, you can see that from hysterectomy incision should be closed only after you apply the B-Lynch sutures. So once you apply sutures applied, try to compress it and hold it in a tighter fashion and see whether bleeding is there or not through the hysterectomy incision. Or if you had already tied it and it's bleeding, then you ask one of the assistant from the vaginal end just to check if there is bleeding is controlled or not. As already Dr. Sehal has mentioned, that the sandwich technique, this is advantage is that along with the B-Lynch sutures, you can keep the Buckley balloon, because B-Lynch suture will take care of the bleeding from the upper uterine segment, whereas this Buckley balloon, it will take care of the bleeding in the lower uterine segment. Then coming to the next suture, that is a Heyman sutures. This was way back in 2002, was done by Heyman along with our own Arun Kumaran sir. And this suture is applied, usually this Heyman suture is applied in patient who is not an hysterectomy incision, that is patient of the vaginal delivery. The incision site, you can go through the lower uterus segment anteriorly and brace it over the fundus, and you can tie it at the fundal level 4 centimeter from the corner. There are some various modifications in Heyman where you can take, can you see the circular, the horizontal cervical uterine sutures can be taken at the level of the internal os, or instead of taking the single suture, a double ligation can be done from the anterior to the posterior, which can be tied at the fundus of 4 centimeter. These are the modification of this Heyman stitch. They come in the third stage, the chow box sutures. These chow box sutures are usually put in patient in cases of placenta previa, anterior placenta previa, or posterior placenta previa. When you are not, when the placenta blood is bleeding, and you are not able to see, especially if it is an anterior end. So it is nothing but a square sutures where you have to start at A. You can get into the myometrium, go to the posterior myometrium, take a suture from the posterior myometrium and come out of the B. And from B, you go vertically to C and get into the myometrium to the posterior myometrium and take a transverse incision, transverse suture there, come out there. This is a way how the chow stitch occurs. You should put the 2 in the upper uterine segment and 2 in the lower part of the upper uterine segment. Not more than 4 stitches need to be put. So it also has some modifications where sometimes the 4 sutures can be put in the upper or lower part of the upper uterine segment, or can be put in the lower uterine segment, especially in cases of this placenta previa. So we have so many brace sutures. Yes, it has one study has shown the success in achieving hemostasis around 70 to 100% of patients, but it has its own complications. We have seen cases who are coming with uterine synechiae, Asherman syndrome. Patient might have amenorrhea, and sometimes patient can have uterine ischemia because you are cutting the blood supply for all the areas. The uterus can go ischemia, can undergo necrosis, and also patient can have internal infection. And sometimes when you put a Bareilly sutures, there is chances when you use a non-absorbable sutures, the strangulation, when it becomes loose, there can be a strangulation of the intestinal loop or abdominal omentum can occur. We had one case of uterine ischemia where a patient came with a refractory PPH, and we tried to, since she was young, 28 years old, we tried to save her uterus and we tried to put that Bareilly sutures, chow stitches, and since the hemorrhagic stability was improving, so we thought, okay, let us put on conservative management. We gave blood transfusion. But on day 7 or day, I think so on day 14, something patient came up with foul smelling vaginal discharge, and she was completely asymptomatic, white as white, but she was having foul smelling discharge. So we proceeded with doing the laparoscopy. Believe me or not, when we opened it, it was a papery thin, a flabby, it was almost necrotic. So we should try to put these sutures in the early stages, not at the latest when the patient hemorrhagic becomes unstable. So according to FIGO and ICOG recommendations, they recommend that compression sutures as one of the options to control PPH when medical and non-surgical treatment modalities fail, and also recommends putting out for one laminated diagram of the brace sutures to be kept in theater, especially for all the people who are not well versed. It's an easy suture. They can be to start putting these sutures before the senior obstetrician comes on the ground. Okay, then next coming to stepwise devascularization, the principles. We all know that pelvic vascular sutures, they are the main nourishment to all the pelvic organs. So selective ligation of these major blood vessels will reduce the blood supply and helps in controlling the PPH. It does not treat the cause of PPH, but it decreases the perfusion pressure. So while other treatment is going on, you can try to do this because it has shown that it decreases the arterial blood flow by 49% and pulse pressure by 85%. So this, along with the compression sutures, when you perform quickly and safely, it is shown that the chances of decrease of postpartum hemorrhage ranging from 40 to 100%. Very important when you're doing the devascularization, the knowledge of the origin, the distribution, and anastomosis of all these genital arterial pedicles being ligated is a very must. So uterine, first whatever we do is a uterine ligation, and we already know the uterine ligation, you should be taking at least 3 centimeters below the uterus transverse incision. It has to go into the myometrium. This is the thing, 3 centimeters you have to pass into the myometrium, go posteriorly, come out through the avascular area in the broad ligament, and tie the sutures as close to the uterus as possible. Many times I've seen people taking only to the broad ligament. Kindly, you need to avoid that. You need to take in myometrial tissue whenever you're doing the uterine artery ligation. So uterine branch of ovarian artery can be ligated just below the uterine over ligament. That is this modification of old oral stage. Along with this uterine artery ligation, whereas a uterine over anastomosis, you can take in ligation over here. That also have shown to control the postpartum hemorrhage. The success rate of this is around 42 to 80%, but all it depends upon the timing of the intervention from the beginning of the bleeding, the presence of any coagulopathy, and the expertise of the surgeon. Still, we don't have any control studies to show that only uterine artery ligation is effective enough in controlling the PPH, because most of the time it's a combination of this uterine artery ligation with the uterine ovarian or internal iliac artery. One of the modification steps of morals, there is a 4 ligation. One is the one what you see is a distal uterine ligation. The 2 is a round ligament ligation. 3 is the uterine oral ligation, and 4 is this proximal uterine ligation. This is one of the modification. Ultimate you get is the internal ligation. This is a posterior view of the vasculature supplying the uterus, and this is a place where you apply this thing and reduce the vasculature, decreases the pulse pressure and blood flow into the uterus, and tries to control the PPH. So most of the people know the anti-division of internal artery ligation. It's very important. It was when all medical non-surgical approaches are complaints which was faced, this becomes very important in ligation, which was first performed by Kelly in 1894. It not only affects and prevents the need for hysterectomy, but also even if hysterectomy is needed, it also facilitates that the area looks very clean. And whenever there's extensive general surgeries, when you occlude the internal ligation, the blood flow, pulse pressure decreases, and the bleeding also reduces, so it is easy for us to operate in that area. So the main physiology this is it changes from arterial system to venous system and decreases the pulse pressure by at least 85%. The steps I just want to tell you, there's a beginners just between the uterine but round ligament and the infundibulopelvic ligament. You try to open this peritoneum. As you try to open the peritoneum, you have to you have to see for the ureter course. So identify the ureter and try to retract it medially. And then you have to go further down and longitudinally open the sheet which is covering the internal iliac artery. So once you identify this is a common iliac artery, this is a external iliac, this is internal iliac. Internal iliac, you have to identify the anterior division and the posterior division. And 3 centimeters from the anterior division, a right angle clamp is passed usually from lateral to medial side. Because if you pass from medial to lateral side, you have an external iliac vein which might get punctured and it's very difficult to break. So slightly you have to do the dissection, go from lateral to the medial side, take 2 non-observable 206 sutures which are placed 2 cm distal to the bifurcation, and it is usually done either unilaterally, bilaterally, but most of the time it is always better to perform bilaterally. This is one case of placenta accreta. Can you see? This is an internal iliac artery ligation, and this is a non-observable 6 sutures taken from at least 3 centimeters from the anterior division, and these are the 2 sutures which is placed at a distance of 0.5 centimeters. Complications, it doesn't have much complication, but you need to have a high degree surgical skill and training, because if at all we are not able to delineate properly, there's more chance of injury. Posterior division can be ligated, which can lead to the ischemia of the legs, or can be lead to the injury to the external iliac veins if not done properly. So the potential complications you should be remembering, and I think the FIGO recommends that internal iliac ligation as one of the best options to control when medical non-surgical complaints sutures fail. And it also tells that all obstetricians should familiarize themselves with the internal artery ligation and with the technique of it, how to ligate, location and its ligation. These are some of the modification by Nikova's ligation, where the 3 stitches are put. One is at the distal uterine artery, one is at the round ligament, and one is the uterovarian anastomosis. And Rabo's modification, he has put one on distal, one on distal uterine artery, one is at the proximal uterine artery origin, and one at the infundibulopelvic ligament. These are the various modifications. Coming to the total hysterectomy, I know this is one of the easiest way of saving life, but you should not keep it till at the last resort. Okay, let me try all those things. By the time you might lose a valuable time. So depending on the patient condition, that's why I told you very important to talk to the anesthetist. Depending on the patient condition, you need to proceed it as early to save the life of the patient, and it should be performed fast. Consider when you have to consider this. When the blood loss is resulting in a profound hemodynamic instability, when extensive uterine and genital tract trauma with extensive vascular involvement is there, and sometimes in uterus rupture, when you're not able to properly delineate all the tissues, yes, you need to have a you cannot do, then you have to go proceed for the hysterectomy. Morbidly adherent placenta, non-amenable to dissection and delineation, and damage controlling surgeries. So hysterectomy, as I told you, when all the other modalities fail, yes, you would go for hysterectomy. And in not necessarily when in non-expert hands, when you're doing it, just subtotal hysterectomy can be done even when to stabilize the patient immediately. But whatever the decision for hysterectomy should always be taken by expert consulted decision along with one of the other senior consulted decision, because the reproductive capacity of the woman will be lost even if it's a primary or young patient. So you need to take a proper decision when you're doing the hysterectomy. Okay, so according to ICOG 2016, early recourse hysterectomy is recommended, especially where bleeding is also with placenta accreta or uterine rupture. So I just came to one meta-analysis study which was done in 2023, the incidence, indication, risk factors and outcomes of emergency peripartum hysterectomy worldwide. It has shown that the incidence of hysterectomy is 1.1 per 1,000 live birth, and this was more in the lower middle income settings compared to the high income settings. And the main indications are placenta pathology, uterine atony, uterine rupture. And they've seen that complication injury to the bladder, bowel and ureter has been noted in these patients. Okay, this is the various steps of peripartum hysterectomy. You need to remember that the new thing is clamp drop. No need to take a suture, just clamp it, cut it and drop it, and later once the uterus specimen is out, then you can start doing the ligature. Since most of these blood vessels are very tortuous, so very important when you're opening the broad ligament when you're clamping the corner frontal structures, and the course of ureter is also very near. So it's very important. We need to first do the round ligament, then you open the posterior leaf of the broad ligament and take care that avascular area to be taken. Then after you clamp, double clamping should be done for all the pedicles. And very important, fourth thing, which you are open the posterior peritoneum. By doing that, the ureter is go more lateralized. Then you have the uterine ligation, and then you have this McEnroe ligament ligation. Then coming to the what? Sometimes it becomes very difficult to identification the vault, identify the cervix. So when you are doing a hysterectomy incision, you give a hysterectomy incision, put your fingers inside and feel for the lower border of the cervix, then you can clamp it. So cautions. So whenever you have an accretal suspected, leave placenta in situ. Very important identification of the ureters because it is dilated in pregnancy. And dilated vasculature, I told you, you have to create a careful, creation of a window when you're clamping the broad ligament, and always double clamping should be done. Take control of all the things when this process is going on. Need to have a maintain the airway, the oxygen, ventilation, supporting of the circulation, as I've already mentioned by Dr. Snehal, and prevent hypothermia. So this very important point, you don't have to rush the fluids. It's very important. Only 750 to 1 liter of fluid only should be rushed, and thereafter only blood should be given, because it has shown that increased IV fluids leads to decreased concentration of fibrinogen, hemoglobin and platelets with prolonged PT and PTT time. So when you do aggressively, when you do more than 1.5 liters, the studies have shown that it aggravates the dilution of clotting factors and also results in increased hemorrhage volume, decreases oxygen delivery, decreases survival rates, and may impair the clot formation, might disturb the fibrin polymerization. So very important, you have to do restrictive fluid management. But one study I have shown that by doing restrictive fluid management, you might compromise the renal function. And this is massive transfusion protocol. Everyone should remember when you have to initiate the massive transfusion protocol. So whenever there is a whenever you have to replace more than 50% of the blood volume within 2 hours, and start continuing with the 4 transfusion, 4 unit of packed cells within a short period of time within 2 hours. So whenever 50% of blood is lost, I mean, you're given 4 packed cells within 2 hours. Yes, you understand patient is going, you have to tell the blood transfusion medicine department to initiate the transfusion protocol. The round 1, you have to give 6 units of PRBC, 6 units of FFP, 6 units platelets, and 10 cryoprecipitate. Even that it is not controlled. Second round, same thing should be given. Third round, you have to give tranexamic acid, and fourth round, you should not give cryoprecipitate. Only PRBCs, FFP, and platelets should be given. All this coagulation pattern should be repeated periodically, and level of fibrin should be maintained above 150 to 200 milligram per deciliter. Okay, coming to the last one, the damage control resuscitation or damage control strategies. What is this? This is to minimize PPH in parturients who may not survive surgery, and to prevent the deadly combination of coagulopathy, acidosis, hypothermia, and to maximize the tissue oxygenation. So what does it do? It focuses mainly on the resuscitation, hemostatic reanimation, and bleeding control. So it can be done by damage control surgery or by interventional radiology. So a staged surgical approach that minimizes the operating time, differing the definitive surgical procedures until a normal physiology is restored at the intensive care unit. So what are the indications? There is an indication is that first, if the systolic blood pressure is less than 70, body temperature is less than 34 degree, meta pH is 7.1, venous bleeding not suitable for surgical control. All these are the things which the patient should undergo damage control surgery. What are the steps? Steps 1, initially you do the laparotomy, control the hemorrhage by hysterectomy and pelvic packing with temporary closure using the Bogota bag. Bogota bag is the one which covers it till you go for the definite surgery. So usually definite surgery after resuscitation and stabilizing the patient can be done 48 to 72 hours after initial surgery, and later you can do the definitive closure of the abdominal wall. Complications, infections, collection in the cavity, and evisceration of the organs can occur. So aftercare all depends upon the response of the patient and not mainly based on the parameters. So that you should be remembering it. Unanticipated PPH, yes. Whenever you unanticipated PPH, always call for the senior obstetrician anesthesiologist within 10 minutes of time, administer oxytocin within 10 minutes, recognize the cause of PPH within 10 minutes, and do all corrective measures for controlling the uterine toning within 40 minutes. If not occurs, surgical procedure start within 1 hour after the delivery. So in conclusion, I could tell that the key to successful management of any PPH is to anticipate, assess the cause of the blood loss, where the blood is going, how to respond, arrest the bleeding, avoid circulatory and coagulation collapse. It not only surgery, circulatory coagulation preventing is very important, ameliorate and prevent of complications to end organs, and awareness. So this is algorithm in the management of PPH given by the ICOG 2016. And this is my references. And this is one mnemonic for hemostasis control of PPH. I thank you all.
Wonderful presentation, Dr. Chitra.
Thank you, ma'am.
Sujata, would you like to say something?
So it's, I think she has covered all the aspects.
Everything.
And everything she has covered since beginning to end. And really, when the PPH is going on, the first thing which comes in the mind when the patient is going to low, that ab to iski hysterectomy kari do. But it is very, very important when you are taking this step, you have to be very careful and take the second opinion from the seniors also. That is very, very important. So when you are deciding what is the factor, if there is blood is available, everything medical management has been completed or not, then you have to take the decision of the hysterectomy. Meanwhile period, you can do many steps like the B-Lynch and the Chow square. Many times these simple steps are very, very helpful. But one thing I share to you with all of you, that one patient I have seen the complication of the B-Lynch from the one place that referred to us. They have put so much tight suture. So it is important when you are putting the sutures on the around the uterus, you have keep one finger in and then you put that one finger loose should be there. That is very, very important. Otherwise, hemostasis is too much, necrosis occur. So one patient come to us and we ultimately have done the hysterectomy to save the patient. So it is very important when we are putting the B-Lynch. Otherwise, you have covered all the aspects of the surgical management very nicely.
Thank you.
Thank you, Sujata. So I would like to say that really, I would like to say, Chitra, your talk was mesmerizing, And
thank you so much, ma'am.
The other thing is that your action has to be like Chitra. You have to be fast.
Yeah, ma'am. The way you manage the PPH should be as fast as my talk. So you should talk fast the same way you have to
Exactly.
Yeah.
You should be as swift as she was speaking. And actually, it's not a fault. I told her to limit it to 15 minutes.
No, but
he initially only said, I'll have to, somehow squeeze it in.
Yeah.
So nice. Thank you so much, Chitra. It was so nice of you.
Add over here, that's about the everything. There has to be an indication for the B-Lynch or the compression sutures. When you are applying it, you must always do compression first to find out whether the bleeding stops or not. So compression sutures will only be beneficial if you are able to control the bleeding by doing the compression. Internally or externally, whichever way. Chitra, is there any type of sutures I read about the transfer sutures which are also being applied? Especially
actually, the global stitch, it's called global stitch, ma'am. But studies have shown that when you apply global stitch, it leads to more of necrosis. So it's better because.
And the other thing is that there are, instead of B-Lynch, you leave the decidua. You take the stitches. Those are stitches coming because just for that. And the necrosis part, this Sujata has already said. And the other thing I would like to say over here, whenever we are ligating the uterine vessels, it's not artery, it is the vessels which have to be ligated. Both the things happen. The artery and the vein, both are ligated.
Uterine vessels.
On the contrary, when we do the internal iliac, you have to spare the vein. You just cannot. So one has to be very, very careful, and somebody like Chitra, you manage PPH.
So far.
Impressed. Yes, very impressed, Chitra.
Thank you so much, ma'am.
Thank you, Ranjana. Thank you, everyone.
I'd like to thank our guest of honor, Dr. Sheela Mane. Ma'am, we all are aware of your exemplary work in the field of PPH. Thank you, ma'am, for disseminating knowledge relentlessly in every nook and corner of the country. I want to thank ICOG office for always recognizing our webinar and giving us points. I want to thank all the societies, Lucknow, Bareilly, and Allahabad, for always helping us and holding our hands. And I want to thank chairpersons for today, Dr. Manju Verma ma'am, Dr. Shubha Pandey ma'am, Dr. Lata Agrawal ma'am, Dr. Nidhi Chori ma'am, Dr. Sujata, Dr. Gayatri, Dr. Meera, Dr. Mridula for all valuable inputs. I want to thank all the speakers, Dr. S.P. Jaiswar ma'am, for explaining the physiology and normal management in a very classroom way. Dr. Khanna ma'am for imparting knowledge about this upcoming molecule, and Dr. Sheela for your explaining all the things about Vandal approach in a very crisp and clear way, and Dr. Chitra for explaining all the surgical approaches in a very we all have praised you. And thank you in the crisp and clear way. Yeah, and thank you, Parul, for assisting me. Thank you, Ma, for always helping us for taking ICOG points. Thank you, Jagsonpal, Dr. Deepika and Amit for always giving us technical support. And thank you, audience, for joining us in this webinar. Thank you so much. Bye-bye for next till we meet again.
I would also like to take this opportunity, thank everybody, all the faculty and the attendees who were present. Just a few products that I would like to display. We have Divatrone, micronized dydrogesterone 10 mg tablets.
And the first runner-up is Divatrone from
So this was the AVEX Marketing Excellence Award. So thank you all very much and we hope to see you again.
Thank you.